in a public meeting, and we should be open and honest about that. Minutes of the meeting on the 29th of September, are you happy to refer record? Good, and the action log, all the actions are complete, so I think we're okay with that. On my report, couple of things really. We welcome 5 new public governors and 5 new staff governors recently following an election process as governors at KGH, and they came to an induction event on the 26th of November, and they take up their post on the 1st of December for a 2-year term. So those of you that are coming into the governors meeting tomorrow will see most of them there, where I'll ask them to do a little intro on what interests them and their background and so on. So you can meet them there. We ought to report that we also, since the last meeting, the appointment has been made of Toby Saunders as the substantive integrated care system chief exec, although there are some complicated technical issues around the recruitment of the next level down. And finally, in that context, the adverts are appearing for the non-exec directors of the integrated care system. And we would expect the Integrated Care Board to meet in shadow form in January, I think, and then go live in April. And like a lot of new boards, it's going to be pretty important how that plays out, what the new board does that makes it different and better than previous ones. And for information, we have 2 new non-exec directors who you will meet at Northampton. We have Professor Andre Ng, who is Professor of Cardiology, who replaces Tom Robinson and is the match for Edmund Burke in the sense of being the University of Leicester rep on the Northampton board, and who will chair the Quality Governance Committee there. And we have Elena Lapteva, who is in due course going to become the chair of audit there, and comes with a background of financial management in hedge funds and venture capital in a wide variety of countries around the world, and comes with an Eastern European ethnic group. So that's enough from me. Simon.
Thanks, Alan. 2 things to highlight today from my point of view. The first, I think, concerns our current position around non-elective demand and how we as a system are responding. Before I talk a little bit about that, I just want to pay again, on behalf of us all, a great tribute to the people who continue to get up every day and provide emergency care services across our county and in our hospital. They are in the middle of probably the most difficult winter, or just at the outside edge, probably to be more accurate, the most difficult winter many of us will remember. And I think it's important that we continue to acknowledge their contribution and thank them for it. Demand, I think, and where we are at the moment does require some consideration, and I want to make probably 2 or 3 points around that. The first of those is we need to make sure we are doing all we can to get patients home as soon as possible. And in doing that, we need to make sure that we're not over referring patients to higher pathways or higher bands of care than they need. I know Alan is fond of saying the one place where there are plenty of beds is in people's homes. And if we over refer into higher bands of care, we don't make best use of that. I commend the work that people are doing. There is more that we need to do. That said, as Northamptonshire, we're marked out by being one of the higher counties where we still have numbers of delayed discharges by any stretch of the imagination. That is, as I think I've said before, the Gordian knot that we have yet to cut sustainably in this county, and one that we must make progress on. To do that, we frankly will need our system partners' help. And going back to the point that Alan just made about the integrated care body, this allows us, I think, a chance to have different conversations about how we will operate going forwards to reduce the risk that at the moment I know people feel sits far too heavily on our side. I know that system partners don't want to see this, but I would also have to acknowledge on behalf of our staff that we still face the situation that I've described. Finally, there's a lot of work going on to look at what further investment is required to help support our system. I would say that particularly for the next period, the problem that we face in H2 is not one of money fundamentally. And this points to probably the most significant problem that we have in this county and indeed counties around us, but it is of workforce. We cannot recruit staff, particularly in the care setting, to do the jobs that we now need them to do. And I think increasingly we are going to have to get on the pitch to help support some of those deficits in the care setting. Otherwise, we will not get out of this position in which we find ourselves. Very simply, winter is not really a period of time which we will recover from. It is something that will continue well into next year, particularly in the care setting. The second thing I just want to allude to is the clinical strategy. Firstly, I'd like to thank Matt, Rabia and Polly for all the work that they've done to get the document to where we got it to and what is in front of you today. It is, of course, incredibly important that although we are dealing with the tactical operational issues around winter, we do set a course for the longer term. In my view, organisations that fail to plan for the longer term are the ones that make incremental additive decisions that ultimately don't get them to where they want to be. I want to say a couple of things about the document that we will debate later on in our agenda today. The first is, despite the many challenges that assail the NHS, we've got considerable opportunities in this strategy, and I would encourage us to be optimistic about it. We do have a real opportunity to do better for our patients, and hopefully you will see some of those ideas contained in the document. We've started particularly focusing around cancer and cardiac services, where we think there are significant opportunities to help develop our services in the current offering. There are plenty more of those. Equally, we need to be mindful of the fact that the other challenge is that there are services that are struggling in Northamptonshire, acute services that are struggling either here or in Northampton. And we now have a real task to make the best of the resources that we've got across the group to try and sort out some of those problems. And we will need to work at pace. We can predict that the workforce crisis is going to continue to develop. We know that we will have to start to rebalance the funding in a post-pandemic world. And we also know that patients rightly expect us to continue to deliver improved quality of services to different levels of standards. So we need to act with some urgency in order that we deliver what we know is within our grasp to deliver. So I'm really looking forward to that debate today. One final thing, I should say, this is a pivot point. We are presenting our ideas here today. They are our ambitions, but we really need now to engage fulsomely with our stakeholders to get a sense of what they think of these, think of our plans. And so it's the opening of a conversation that we need to have across our system, as well as with ourselves. Thanks, Alan.
I'll roll straight on to Debbie, and then we'll take any questions or comments at the end. Debbie, over to you.
Right, thank you, Chair. So I'm going to start today with an update on COVID. Despite the recent news, we've currently got 32 patients in our hospital as of today who are COVID positive. 3 of those patients are in ITU. So as you can see, the numbers have started to decrease slightly, as is the acuity in our hospital. Whilst the numbers of admitted patients are stable, the total number of patients waiting over 7 and 21 days has increased, and we'll talk more about that in the IGR later on in the agenda. Our system winter plan has been noted as one of the best in the region by NHS EI, which is really positive. We are making strides to increase capacity in the community, as well as recruit to some of the posts that have been historically really difficult to recruit to. The likelihood is, though, that we will need to continue to try and spot purchase nursing and residential home beds as we go through winter, because we know that we are not going to have enough beds unless we do that going through January to March. So you can see also, as we go through the IGR later, our occupancy is still really quite high in the organisation, but we are continuing to undertake some inpatient elective work. We're still continuing with day case and outpatients, and we haven't had to cancel any of those due to emergency pressures as yet. And with that, our performance is still remarkably good. Again, one of the best in the region, but still just below target. I'll now move on to Crazy Hats charity. So earlier this month, I received a final cheque from the Crazy Hats charity. And over the 20 years that they have been a charity, they've raised more than £1 million for Kettering. So I'd really like to just take this opportunity to say a huge thank you to Glynis and the team for all their support that they've provided over the years, not just to Kettering, but also to Northampton General. One of the other things that I have been up to in the last couple of months is that I launched Coffee and Chat with the Chief Exec, and I met with our medical secretaries. We discussed quite a lot, and they're really keen to make some changes within their own services and within their the way that they work. Some of that was around how they work, working from home, how they communicate with patients. And I'm really pleased that they're now setting up what is going to be our first decision-making forum council to progress some of their ideas. We've mentioned a lot about the Never Event learning session, so I won't go into detail on that. I'd just again like to pay tribute to Mr. Toop for his openness and honesty, and also to all of the staff that were involved in the Never Events, because their reflective sessions that they had within the learning session, but also prior to that with myself and Rabia, were quite humbling, and we learned a lot through those. And then finally, I have been in touch with the Chief Constable for Northamptonshire, and following sad deaths of a couple of ladies in the community over the last couple of months, we will be holding a session with our female staff and male staff, if they wish to join, with the Chief Constable of Northamptonshire on female safety in the next month. And I'll stop there. And that's that. Just before I finish, that is a session that will be across the group rather than just Kettering. But I'll stop there. Thank you, Chair.
Okay, thank you very much, both of you. Any comments or questions about any of those 3 contributions? No, I'm not seeing anything. I think we'd all join in congratulating Crazy Hats for what they did. It was quite a remarkable group of people, and I suppose all good things come to an end, but still, they were quite a remarkable crowd. Okay. Straight on to the integrated governance report then. So it continues as the Debbie Needham show. If you would run this session, Debbie, that would be excellent. Thank you.
Yeah, of course. Thank you, Chair. So can everybody hear me okay? I'm on my iPad today, so it's a little bit different. Yeah, thank you. Okay, so you'll see from the integrated governance report that we've made some progress in some areas, but we've still got quite a lot to do in other areas. And that will continue throughout winter. We've also heard from Simon earlier that this is likely to be one of the most difficult winters that we face within the NHS. So what's really important is to continue to maintain safety, to care well for our patients, but also to try and improve some of our performance targets. So I'm going to start today with quality and safety. I will hand over to Chris, and then I'll bring Fiona and Rabia in. So Chris, are you happy to come in, please, on quality?
Yes, thank you very much indeed. So we had a Quality and Safety Committee meeting on the 23rd of November. In the pack, slide 20 shows the 5 things that we wanted to report up to the board, and I'll come back to those in a moment. But we also had some really good discussion about the impact of the pressures that the hospital is under at the moment that could have an impact on patient safety. So that bed occupancy is 95% plus. The number of stranded and super stranded patients, those remaining in more than 7 days and more than 21 days, had increased very significantly. Part of the story there is part of the another pressure is staff availability as a consequence of illnesses. And then we spoke at length about 2 COVID outbreaks that had happened and the actions that had been taken to uncover the root cause and the consequences. We noted the changes to the Director of Infection Prevention and Control, and that's later on the agenda. The Never Events event, and we also spoke about mortuary assurance in regard to security of the mortuary. And I will stop there and answer any questions if anybody's got any.
Thank you, Chris. Fiona, anything to add, or Rabia?
Thank you, Debbie. We had a really good meeting, so thank you for Chris for referring to it, because there was some in-depth discussion and some real detail in regards to how we manage infection prevention, in particular around our outbreaks and C. difficile in particular. And it was a really helpful discussion for those there. I'm happy to take any questions in particular around the topic areas.
Thank you, Fiona. Rabia?
Thank you, Debbie. I think we've covered quite a lot around safety, and that's what I was going to just provide assurance on, that with regards to our enhancing patient safety program. We've already talked about it, so I'm more than happy to take any questions on that.
Thanks, Rabia. So colleagues will have seen in the press the very sad incident that's happened with regards to a member of staff accessing a mortuary in a South London hospital. I would just like to assure the board that we've done a huge amount of work on this, and you'll hear about what we've been doing later on today. So if we can then go to performance, finance and resources. Damien, are you happy to start, please? Oh, Janet, you've got a question. I can see you waving.
Hi, thank you very much. I'd just like to raise a question around complaints, and Debbie, if you could say anything at all about what's happening in the organisation to review the approach to complaints, I'd be grateful, because they're obviously at a particularly low spot.
Yeah, absolutely. So there's quite a lot that we're doing with regards to complaints. If I first start with the letters, we have reviewed how we are communicating to patients, and we are now making sure that each director who, if the complaint sits within their portfolio, sees the complaint and also signs off the individual response. That's the first thing that's happening. We're also using a template that NGH has used in the past for our complaints, for our complaint responses. The second thing that we are doing is the complaints team are working with the divisions and directorates, and specifically the service managers and general managers, to make sure that they are responding and investigating the complaints on time, so that we can get the response back to the individual complainant within a reasonable time frame. And then there is a much larger piece of work taking place with regards to the reasons why patients are complaining. So, for example, communication with our staff and patients is one of the largest areas for patients and relatives to be complaining. We're working with a volunteer team to make sure that we've got people on the wards and services who are answering the phones in a timely manner, who are then providing information to relatives and patients, so that we can then allow the staff to get on with administering care to patients rather than continually answering the phones. I don't know, Fiona, if you want to come in on any of that. Thank you.
Thank you, Debbie, and thank you, Janet, for the question. So the other key piece of work that we've been taking forward is working more closely with the divisions, as Debbie has said, but looking at the particular needs of the divisions in regards to the process and the content of their complaints. So working with our patients' experience team. We've also undertaken, in the process of undertaking, a process map in regards to our complaints process and timeframe, along with NGH, to understand and learn from them what we can be doing differently or what the differences are, so that we can understand, as I've said, and benefit to their processes. And that work is coming to me at the end of next week. And in regards to a request from Chris through the quality meeting, we are looking to share that and have invite James, who you met earlier, our patient experience lead, to meet with the non-execs and governance.
Thanks, Fiona. I hope that answers your question, Janet. I can't see any other hands up, so let's move to performance, finance and resources. Damien, please.
Thanks, Debbie. Good morning, everyone. Can I just check everyone can hear me okay? Okay, perfect. So just starting with the key things that we thought were worthy of escalation to the board, as we've heard about a lot this morning, capacity is an issue, but specifically, we talked about super-stranded patients. At the time of the meeting, which was 19th of November, there were 119 super-stranded patients within the trust. A high proportion of those patients are in that situation because they cannot be discharged into other treatment pathways in social care due to capacity in that area of healthcare provision. However, it should also be noted that there are discharge issues within the trust itself in terms of the process of discharging patients, particularly the length of time it takes to fill out the current PDNA form. We took assurance that the trust is looking at ways to expedite that process. I believe Newton have been engaged to help with that, and there is a trialling of a new SBAR form. I forget exactly what the acronyms mean, but I'm sure if you have a question on that, Debbie would be able, or Fiona would be able to answer that. So it's hopeful that discharging as a process within the trust will improve as those processes and new forms start to bed in. It's also worth noting, and this was kind of new news to me in the committee, that there are 51 less beds within the trust compared to 2019. So it's actually less capacity from a bed point of view. Other things to note, as Debbie has said, unfortunately the trust didn't meet the 62-day standard for cancer treatment. That was 81% compared to a target of 85%, and RTT incomplete performance was 76% compared to a target of 90%. However, what I would say is that there's a couple of charts within the IGR that show the trust performance relative to other trusts in England, and we are in the upper quartile for both. So as Debbie said, it's not ideal that we've missed the target. However, performance is still pretty solid relative to our peer organisations. A couple of other things just to make the board aware of. We received a couple of papers for assurance. The first was the Emergency Preparedness, Resilience and Response Self-Assurance Report. And essentially, this is a report that says, is the trust able to deal with a major incident? That major incident could be pretty diverse in terms of its nature. So for example, you'd have seen in the news the recent event at Liverpool Women's Hospital. It could be something like that. It could also be a cyber attack. The key thing to note is that the committee took assurance that the trust has a way of dealing with these major incidents that is sufficient, and therefore we approved the report. However, the Director of Emergency Planning and Resilience was keen to point out that there are improvements that can be made to that report. So we're going to review it again by the end of March 22 to have a look at the improvements that he and colleagues will have incorporated. We also took a paper from the Director of Estates, which was the Estates and Facilities Regulatory Compliance Report. That essentially gives us assurance that the estate is being managed in line with NHS policy, and that there are mitigations in place for the key risks highlighted within that report. However, we did challenge the Director of Estates to consider whether all of the risks relating to the estate were contained in that report. It seemed to be a relatively small number when you consider the aging nature of some areas of the estate. So again, we will continue to review that within the committee. From a finance point of view, I'll be very brief on this. Month 7th was on plan. We heard that full year is anticipated to break even though there was a half-one deficit of 5.8 million. John will explain in a paper later on in the agenda how we get from the 5.8 million half-one deficit to the full year break-even position. So I won't spend any time on that because John has quite a detailed walk through that. The only other thing to say on finance is that capital spend I guess continues to be an area of concern in the sense that we're worried that there could be an underspend situation. However, we took assurance that there are lots of actions and meetings in place to continuously review that position and make sure that we are able to spend at the anticipated capital spend budget for the year. So that's everything I wanted to cover. Thanks, Debbie.
Thanks, Damien. John, is there anything you'd like to add at this point?
Just on capital, if that's okay. So nothing further to add on revenue. Damien's picked all of those items up, other than perhaps to say that the position we saw in month 7 is very much a continuation of the pressures that we've seen in the early part of the year around higher than budgeted activity levels, higher than budgeted costs of elective recovery, and those additional pressures that we're seeing around unavailability of staff and discharge support. So very much a continuation on a theme. And as Damien said, we'll pick up how we get back to a break-even plan in the H2 planning paper later on the agenda. From a capital point of view, there was a fair bit of challenge in our meeting, quite rightly. We're looking at a position where we've spent circa £3.9 million to date, so 3.9 versus an overall programme for the year of 13.9. That means we need to spend £10 million in the remaining 5 months, for those that will do the maths. I guess the level of assurance provided was that we have committed spend, so those are orders that we have placed but not yet paid, plus the actual spend that we've incurred gets us to circa 10.5 million. So when you're comparing that 10.5 million of spend that we have committed versus the 13.9, the gulf between the two isn't quite so large. And what we've agreed, following a request from Damien and committee chair, is to come back to the next meeting with a monthly forecast of spend, both in committed spend terms and cash, and basically take the committee through those decisions that we need to make. It would be remiss of me if I didn't describe that there are still some decisions that we need to make as a board to close out our year end in line with the plan, specifically around the HIP2 programme, radiology spend, and whether or not we have the ability to invest in some other specific imaging equipment, and we will be working through that in the coming weeks rather than months to get us in the best place possible. I flagged to the committee that we were seeing some short-term challenges on cash. I provided assurance to the committee that those were absolutely expected to be short term. We've implemented a revision to our payment terms where we are paying invoices on the terms of those invoices rather than as soon as they are approved. So that is us moving out to terms, not extending terms. So from a kind of approvals point of view and delays to suppliers, that isn't an issue. But it means we're able to manage cash between now and, or between the committee and mid-December, when as part of our H2 planning process, I've agreed with Northamptonshire CCG that we'll receive a significant amount of cash for system funding to come through in both December and January, and that will allow us to manage that cash position through now and year end. So just those that kind of added assurance around capital and cash. Thanks, Debbie.
Thanks, John. I can see that Trevor's got his hand up. Trevor?
Thank you, John. Thank you, Damien. I think my concern on capital, I hear what you say, but over the COVID period, we had to go through not necessarily the full normal routes to make capital procurement. And so I just want assurance that in terms of spending this money, we are actually following the proper procurement processes in all cases.
I'll pick that one up, Trevor. So it was acknowledged by both myself and Debbie that we got halfway through the year and there was a not insignificant gap between actual spend and our forecast spend. We have implemented a weekly review with all key leaders, both procurement, estates, strategic estates, and digital, to work through how we can best prioritise that spend. One of, or two of the key questions when we're assessing any programme and the likelihood of spend is, what does a compliant procurement timeframe look like for us, and what is our ability to physically get, if it's building related, people on site to complete that work. So yes, as you would expect, those questions are working and we have the right people, the professionals in the room for us to be able to receive the right advice and make the right decisions. From my point of view, this isn't entirely about us just hitting the target. It's us ensuring that we deliver the best plan to get the best value of the money that we have available to us. And that's why we put in that kind of proactive kind of decision making this side of Christmas.
Thanks, John. Faye, is there anything that you'd like to add?
Yeah, thank you, Debbie. Just to just pick up some of the work we're doing around discharge, if that's okay. So as Damien's just mentioned, we do have and have had some internal pressures in terms of how we're managing our discharge process. So over the last couple of weeks, we've worked really hard to put two things into place. The first one is to ensure that we can really have some oversight in terms of our PDNA, which is our document that we complete to identify which pathway patients need to be discharged from the hospital. We've now got really good oversight in the form of a dashboard, which has been developed by Newton. And the second part of that is also around the decisions made at the MDT. We were going through a period of time where patients were being discussed at the MDT and then we're going back to the wards for more information. We've now stopped that. All decisions and information required is dealt with within the MDT, and that's shortening now the time it takes from a decision to be made to the patient's discharge. And we hope to see some real improvements in that over the next couple of weeks. Starting tomorrow with our partners, we'll also be looking at all of the top 50 patients. So every patient on the super stranded who's medically fit, we will be targeting and expediting their pathways where possible. As Simon mentioned earlier, sometimes we do overprescribed care, and this MDT will be around looking at that to see if there's alternative pathways. We'll also be inviting our Age UK volunteer partners to join us to see what they can also do to help. We're also doing a piece of work with adult social care around what can we do to help them. Clearly, we've got significant issues in terms of recruiting, particularly for patients that want to go back to their own homes. So we're looking to how we might support them with our volunteers, but also whether we can get more people onto our bank who might also like to help and support social care and patients in their own homes. So there's quite a few actions that are happening, and I'm hopeful that we'll see some improvements in those numbers and the reduction in super-stranded patients in the next few weeks. Thank you, Debbie.
Thanks, Faye. I can't see any other hands up. So if we are able then to move on to the People Committee, and Janet, please.
Thank you. I think you can see from the report that some of the performance metrics are not doing so well. We've heard from John about the unavailability gap, and clearly the pressure on the workforce is really significant. I'm pleased to say that, having sat in on some of the listening events, some of the key issues around that are being dealt with. We know that the staff survey responses at the committee staff survey responses reported to the committee when we met were not as good as they have been previously. So I'm sure Mark will probably give an update on that. Things like the statutory and mandatory training, I think our colleagues have really been making great efforts to look at different ways of being able to deliver that. And the committee asked for an update on safeguarding. That links really with the patient's story that we heard earlier on today, and the training around some of those things being really critical to see that they happen. Appraisal 2, and again, colleagues have worked on a method of being able to get appraisals up to date, as well as looking into exit interviews for people who are leaving the organisation. Although I recognise in the report there's an explanation given for why some of that's happened. A really critical piece is one of the challenges that I think the hospital team are dealing with, and the Chief People Officer in particular, looking at vaccinations of all staff. And so that was raised at our committee in terms of the complex nature of trying to resolve a situation like that and make sure that people's wishes and stuff are respected. So I'm aware that that piece of work is going on at the moment. We've also asked, because of the things like the clinical strategy, for an update on the progress on things like joint contracts and joint bank. That's obviously critical for critical consideration for a clinical strategy as we go forward. Things like joint reporting on nursing midwifery, again, some progress made. We anticipate more in January. And now I'm going to raise a particular issue that I've heard is around car parking. I'm just going to ask in a moment if I can have an update on how that's progressing in terms of staff walking to the car park, given the point you mentioned, Debbie, about the training opportunity. But I would also just like to say that the Trust has been commended in its work on wellbeing with the Health Service Journal. And I was delighted to be party to the awards event last week, which I think was really significant to look at the achievements that have been made by the workforce. So thank you very much for a fantastic event and for being able to showcase the achievements of our workforce in times of a really critical situation. So thank you.
Thank you, Janet. I'll bring Mark in now and then answer the couple of questions that you have afterwards, if that's okay, Mark.
Yeah, of course. Thank you. Morning all. Thank you, Janet. It pretty much covered everything, as you'd imagine, in sync working together that I was going to mention. I will just mention a couple of points, yes, around the vaccination programme. So we have established a task and finish group to work through the mandated vaccination requirement that will be placed upon our hospital in the very near future. We're just working that through at the moment. As you saw in Debbie's report, however, we are still vaccinating for flu this year, and we're going great guns at that, with 59% of people having received their vaccine and a number of people having received their COVID booster as well. So we're just working through the mandated piece as it stands at the moment, and of course we'll update the various committees and indeed the board in terms of any potential impacts or risks and impacts that may have for us. From a staff survey position, we have received, or it closed on Friday, and unfortunately we did receive less people completing the survey than we did last year. We're just in the final rounds of counting those up at the moment, but it appears that we're in the mid 45% bracket this year in 2011. We hadn't changed much of the plan. A lot of it came down to the pressure that people are under and their availability and time to complete the survey. We did all that we could to try and incentivize and to try and support people to provide them with that time. But given the pressures that we've heard during the course of the meeting this morning, it just was something that was too difficult, colleagues found on this particular occasion. The other element that I just wanted to pick up is that, as Janet has mentioned, in regards to joint working and how we can take that further and a bit quicker. One of the areas for that, in terms of our memorandum of understanding, we're working very closely with colleagues in governance on this at the moment, and we will have it ready for December as promised. And secondly, our job planning policy, a joint job planning policy between ourselves and Northampton will be in situ at the end of January. So we are now starting to move into that modus operandi of working collectively across the group. I'm happy to take any questions.
Thanks, Mark. Simon.
A couple of points from me. So the first was just to respond to a question in the chat, but just to bring it live for colleagues into the board meeting. The social care vacancy rate continues to be a matter of huge concern. And it was one of the reasons why, Lisa, I was referring to the need for us to start to think differently at a system level about how do we attract people to come and work in the care setting. Bluntly, I think if we wait for the cavalry to come over the horizon on this international level, we'll be waiting for quite some time. And I think I'm extremely keen for our people board at a system level, but also for us locally, to start thinking about what are the type of jobs that we need to put out there in the marketplace to attract people to come and work in that setting. Because at the moment, we're not getting the answer that any of us need. And I suspect that's a subject to which we should come back in our people committee, Janet, at a group level, at a system level, and with partners, because they are the real, they are the partners who are most challenged by our current workforce crisis. We may have issues, but my goodness, they are nothing compared to the issues that our social care colleagues are dealing with. The other thing, and it was entirely remiss of me not to do this, so I thank you for mentioning it, Janet. I did want to pay tribute to everybody involved in what I thought was an excellent awards ceremony last week. The challenge of pulling those things off, particularly when they're technically complex, is pretty immense. And those of us that were in the room were very impressed, and it was good to hear. And I think many of us saw the impact it had for staff really positively. So I just wanted to end by saying, I'm sorry I didn't say that earlier. And I was really grateful for you to bringing attention to it, Janet. So thank you.
Thanks, Simon. Yeah, it was a really good event last Thursday, and I think all of us are hoping that next year won't be virtual. We'll be able to do something much bigger and face-to-face. I just want to pick up on a couple of Janet's points before I go into any other questions, if that's okay. So the listening events continue at Kettering. They're really well attended. So they're badged as Now Let's Talk. And it's very much more about talking and resolving some of the issues within the time that we have together, within the hour every week. A couple of things that have come up have been around car parking recently. So we have 2 car parks that are external to Kettering. And some of our members of staff have raised some concerns that they're having to walk to the car parks in the dark, either in the morning or when they've finished. So we've started to do a couple of things. The first one is we've added more lighting, or are in the process of adding more lighting to the hospital site, so that when you are walking off onto the Rothwell Road, it's a little bit more lighter. One of the external car parks does currently have a bus service that runs to and from the hospital. We have started to review the timings, and we've changed one of the evening timings of that bus service to make sure that we can capture more staff come in from work to the car park. The other car park doesn't have a bus service, but the estates team are currently looking into whether or not that can be provided, and I'm hoping to hear back from them within the next week.
Thank you.
Thanks, Janet. Are there any other questions for the People Committee? Can't see any hands up. So if we can move to audit then, Trevor, please.
Thank you, Debbie. So we met on the 1st of November. The main points are there on the paper. I think the key one I want to raise was the presentation that Debbie and co did on the unappointed referrals, a very thorough paper to give us assurance of what was being done. And having done that, we were also pleased to see that the ongoing monitoring of this will rest with the Performance and Finance Committee going forward. It was a major in-depth piece of work that needed to be done, and we were very assured by what we saw. The other key point was that the long-aged problem of completing recommendations seems to be gradually dwindling, and the senior team are completing these recommendations, and hopefully soon we will be only seeing recommendations outstanding that are the ones that have only recently been raised. So thank you very much for everybody's attention to that, and it is a far better position than it has been for well, since I've been with the trust anyway. Apart from that, everything else is on the paper. Thank you.
Lovely, thank you. John, is there anything you'd like to add?
Nothing from me, thank you.
Okay, lovely, thank you. Any questions for Trevor? I'd also just like to express my thanks to everybody who's been involved in the unappointed follow-ups, specifically Faye and Matt Tucker, Faye's deputy, done a phenomenal job on getting us into a much better shape, so thank you. So let's move on now to digital, and Alice, we'll start with you, please.
I think Alice may have dropped off.
Okay. Andy, are you there?
Yeah, I'm here. Thanks. There's quite a big update in the pack today, so I wasn't going to highlight everything. What I will do is just draw out a couple of things that were noted. So the Northamptonshire Shared Care Record is a big thing that's happening this month, or maybe might creep into next week, is about having that availability for our clinicians to be able to use and access GP data for direct care. So we talked about the plan for that and how more data will be increased over the next few months. We had a demo of the Patient Knows Best patient front door, and the pilot is going to be in advanced care planning and maternity with a view, if that works out, to scale it out further. And we'll mention it in the course of today a few times, I imagine, but the targeted investment fund schemes that we've been approved on, one of the schemes is to accelerate that Patient Knows Best as well. So we'll feel more of that over the next few weeks. And we talked about the robotic process automation work. So as colleagues may know, Northamptonshire, hosted by Northampton, is one of the country's 2 robotic process automation centres of excellence. And we talked about how we move that from its current status into business as usual and sustainability. And the final thing I'll mention is around the group digital strategy, which we'll talk about later on today with an update.
Lovely, thanks, Andy. I can't see that Alice has rejoined us. So any questions for Andy, please? If we don't have any questions, we will go on to CPC. Simon, are you happy to give the update to CPC, please?
Yes, given the issues that we are talking about on the agenda today, I will ask the board to take the update tabled here as read and note that we are picking up the items in our discussions in public and private session today.
Yeah, thank you, Simon. Any questions on CPC? Otherwise, we'll move on to strategic development, starting with Alan and Polly, please.
Hi, just two things really. One, this is now a group committee with 10 new terms of reference agreed involving Northampton. And secondly, the process of reviewing the outline business case is scheduled for the private meeting this afternoon, although actually we won't quite be doing it in the way it suggests there. But we are, it's about time to do a review of the outline business case, and the board will be involved in that as we negotiate the politics of the availability of money. And that's all sounds a bit coded, but we'll be taking that in the private session later on.
Thank you, Chair. Polly, anything that you'd like to add, please?
Just a couple of small things, one of which is just in terms of assurance that we're continuing to work closely with the National Hospital Programme team on progressing with our enabling works. So that's an ongoing discussion, but we're continuing our work on that. And the other positive thing is that we have launched under the SDC committee, the KGH Green Team, that we will, so that's a wide group of staff that are all passionate and committed to net zero carbon and establishing what we can do at Kettering and across the group on that. So, but that's it. Thank you, Debbie.
Thanks, Polly. Looking forward to hearing more about that. So thank you to everybody who's contributed to the IGR. I can't see any hands up for any further questions, Chair. So we'll stop there. Thank you.
Okay, thank you very much. Last call for questions or comments on the governance report. No, no. Okay. So that should be the last one of old IGR metrics. And the January meeting should be the first run of the revised set of group metrics. And I'll be talking to non-execs at the away day in later this month about, as we move through January to this revised set of metrics, how that allows us to move more completely to committees in common and in due course boards in common. But that's a debate for the 10th of December with non-exec directors. So this is the latest set of revised group metrics, which will be implemented through January. Andy.
Thank you, Chair. So colleagues, I'll just take you through the sort of final review of these. If you remember, these metrics have been through our various committee stages, and I just wanted to bring it back for you today just to finally formalise where we are. So I'll just jump to this timeline. So this is just a case of where we are. So we've been through the various committee cycles, had feedback, and been through the KGH audit committee, and the metrics are now in development in Power BI, which we'll talk about as I go through this presentation. So as Alan said, we'll expect to see those in the January reports. So this pack that you've seen today will be the last time we've seen it in that format. Even more than that, we'll see this available in Power BI for colleagues to be able to look at any point in the month as the data gets pulled together. And there'll be a training session for colleagues later on this year that we're pulling together. So you will be able to have. It's pretty easy to use, but there'll be an opportunity to have that session to talk about how you get access to the data and what questions that might arise from it. So I'll just jump on to the summary. So if you remember, one of the targets that we had in our discussions was to reduce the metrics in the IGR. So the pack that we've gone through today has got around 57 metrics. The target from Alan was to get that below 50, more towards 40 if we could. And so what you'll see is we've split that out over the strategic objectives and got down to 45 for the IGR. That doesn't mean we've lost some of those other ones. It means that there's opportunity within the committee reviews to actually look at these metrics. So you'll see how those 89 metrics get split down over the various committees. And I'll just jump on from those. Colleagues can have a look at those as we go on. So just wanted to look back to this and just confirm that where we are is delivering those metrics through Power BI and into the January boards. And the proposal is that we will we'll continue to iterate those through committee feedback, but we'll do a formal review of those metrics at 6 months, so we can look back and see where we've got from this report into what's actually felt useful from a practical point of view. So I think what I'm seeking for today is just a endorsement that we're good to go on those metrics as agreed in this report, and we'll work towards the January delivery of those. Thank you.
Okay, thank you very much, Andy. So that really is just an update on things that have been agreed here or in committees before. Any final comments on that at all? No? Okay, thanks very much. So half two planning. Oh, sorry, Chris.
Thank you, Alan. I was just going to say, I think it's great work that we've got down to this number, but could we have another go at producing what I would say might be the top 10 that we want, particularly for non-executive directors who are not living with the pressures every single minute of every single day, so that when we as NEDs switch on, we can see things like what's the bed occupancy, an indicator of the pressure that our colleagues are working under is my request. Thanks.
Thank you. I wasn't planning on giving up on my drive for less is more in this, just pausing for thought, really. Trevor.
Thank you. And I totally support these and also a drive for a lower number. But my concern is that we have the transparency with the divisions, not for us, but they are clear about how these numbers that we're looking at are made up or built up, sorry, not made up, built up, and that is sort of discussed in the right governance forums below the board level to actually make these meaningful.
Yeah, so absolutely, Trevor. I think one of the things that we will achieve through this fire break is for the first time, I think, have a set of numbers that get reported at a strategic level, but then can be drilled down to patient level that is from the same source. And so the dashboards that you will get access to as board members will be the same data that's used on operational level, but will be reported at an aggregate position. So I think what the offer will be is not to just have the IGR as a report that's available on Power BI, but there'll be other dashboards available. And what I suggest is, as we go through the January committee cycle, that we continue to have the discussions and say, okay, how does this first iteration land? Can we adapt that as we go along, and even talk about, actually, is there if you like, a NEDS version of a dashboard that brings together some of those things? I suspect we'll have a really interesting conversation, given that the journey we've gone from 89 metrics down to 45 to get down to 10. I look forward to that debate.
Good show, because I'm sure you'll be part of it. Did you just pick up on the one question in the chat about training for Power BI, Andy?
Yes, absolutely. So we're trying to arrange through Richard May for a session towards the end of December for NEDs and governors to be able to have a training session on Power BI when it's and that'll be using some of those dashboards as they're emerging.
Okay, thank you. Debbie.
Yeah, thanks for that, Andy. I just wanted to give a little bit of reassurance to the board. The 3 clinical divisions at Kettering are currently having a review of their governance post-COVID in the new world. So we will absolutely make sure that the metrics are flowing through from those divisions up to board.
Okay, thank you. So as these come together, there'll be a number of months through the new year where we move explicitly to committees in common that are exactly that, not 2 committees meeting successively for 2 hours. And the compare and contrast data and the opportunities that come from that then become real and meaningful. So that's a conversation and an experience to build on, and then we'll take it forward from there. Okay, thanks, Andy. It's a good piece of work, and everybody who contributed, thank you for that. Okay, half two. This is John. Hopefully, there's Karen. Yes, hopefully joined by Karen, who will take us through the trust and system plans for half two, which we've been through a bit before, but this is the final version, and it is approval required, albeit in some cases retrospective. Anyway, over to you, John, I presume, is it first?
Yeah, thank you, Chair. So exactly as you've just described, we're planning on taking the board through the plan that we have submitted. We've taken this through group board development sessions and discussed it outside of the meeting, but this is for completeness. I'm going to start with Karen, and then I will pick up the finance part, and then other colleagues will come in around ops and workforce as required. Thanks.
Thank you, John. Thank you. Hello all. So thank you for inviting me to your board meeting today. So this is just the plan we wanted to present today is the trust plan, which is part of the overall system plan submission. Key to this will be around the finance elements and which John will talk to, the activity which Faye will talk to, and the people plan which Mark will talk to. As John has said, this is very much part of the system plan submission that's already been submitted, so it's for approval respectively. Key to the H2 guidance is around supporting our staff health and wellbeing for this H2, and particularly looking at elective recovery and restoration of our services to provide the capacity and restoration services for our patients, managing the winter pressures and collaborating across the system to deliver those key priorities. You'll see that we have talked, and we have talked previously about balancing the priorities of delivering our restoration recovery for our patients, balancing the pounds, the money, and balancing the people. This plan does submit an ambitious but realistic plan that does those three things. So we have achieved, Faye will talk to the elective recovery, the financial balance, and then also we have achieved a people plan that delivers all of those criteria. So I shall pause there and hand over to John, who's going to talk to the finance element first. Thank you.
Thanks, Karen. Appreciated. So we're in a relatively unusual situation in that we've had two plans this year. I should have probably picked it up in the IGR section that our month 7 report. So when we closed the books on month 7 for finance, that was actually in advance of us finalising the system plan for H2. So there will be a catch up in month 8, which I'm expecting to see to be an improving position to take effect of what we've now submitted as an H2 plan. So just for completeness, we did submit the plan as a system on the 18th of November. So a couple of weeks ago now. From a finance position, the system has agreed a plan for the whole of the 21-22 financial year. So the first half just gone and the second half to come, with a surplus of £1.3 million. So across the system, across Northamptonshire Care Partnership, we've got a surplus plan for the whole year of plus 1.3 million. KGH's element of that is to deliver a break-even position across the whole of the year. So given that KGH reported a deficit of £5.8 million in the first half of the year, it will need to post a £5.8 million surplus in the remainder or the second half of the year. And I'll talk briefly through the moving parts that get us to that point. We at KGH, along with Northampton General and NHFT, have all produced break-even plans as part of that system plan. And finance leaders across the system have worked in collaboration to get to that point. So all partners have a break-even or better position for this year, which is an important point around system working. So what are the key assumptions? So key assumptions are that our H1 plan, our H1 run rate of spend broadly continues into the second half of the year, but with an additional budget or allowance for specific programs relating to winter, as agreed in our system winter plan, which Debbie referred to earlier on in this meeting. Additional funding to support of circa £1 million to support the our unappointed issue. so additional funds to support that and support capacity to manage that, and some other changes around the phasing or in-year implementation of specific investments. Board colleagues will be aware that we set a plan at the beginning of the year where there are specific investments. They don't tend to start until part the way through the year, and therefore there's an impact if we compare to our straight spend in H1, a higher amount of spend in the second half of the year. So we've adjusted for all of those things or accounted for them to give an appropriate amount of resourcing available. We have also been able to do a couple of other things. We have been able to create a formal contingency in the second half of the year of £1.3 million to manage unexpected risks. And we have been able to manage the impact of changing guidance on the elective recovery fund. So from a resourcing point of view, we are assuming and have allowed for us continuing to spend the same amount of money on additional capacity to support elective recovery as we did in H1. Board members will remember us having a conversation at an earlier board that we made a conscious decision not to step down that capacity. We didn't feel it was the right thing to do for the patients of Northamptonshire, and from a financial planning point of view and from our operational activity plan, that capacity is assumed to continue. We then get to a point of, if we've added in all of these costs, how do we get to a point that we've reached break even given the circa £6 million deficit from the first half of the year? And the simple answer is three things. We are in receipt of some further growth funding from a national allocation of growth in the second half of the year. That totals £1.5 million. We have an agreement with regional leaders that we will receive funding to cover those costs of elective recovery in the second half of the year. That's circa £2.2 million. And then we're receiving a number of other pots of additional financing, really, if I bundle them up, from as part of our system funding allocation to cover off the increasing costs that we've seen and are planned to see over this year, and that totals £20.9 million. So in the papers that you'll see a bridge that explains all of those moving parts, but essentially we've loaded in a load of costs that I've just described, and we are going to receive an additional 20.9 million of funding as from that funding that the system has received. Those numbers then balance us back to break even, and linking back to the finance report that I described earlier on, we are expecting to receive the vast majority of that 20.9 million as cash across December and January. That's what I've agreed with the CFO at Northamptonshire CCG. There are a couple of things to probably flag when it comes to risk and then opportunities. So there's clearly an assumption here that we keep our pay spend levels at H1 levels unless specifically agreed. So that, as I said, that's a winter plan and the kind of phasing of investments. That is going to mean that we need to work through any additional pressures in H2, be it pay rates or other areas. We have a formal contingency, but I think we're going to need to work through both as a hospital and then across the group, that escalation and decision for specifically pay rates during difficult periods to ensure we've got a consistent and managed approach. I'm glad to say that the plan for H2, all of the major income items that I've referred to have been agreed in writing with counterparties, so there isn't and shouldn't be a risk to the income assumptions in getting to break even, which is quite a large departure from where we were at H1, where things were far less clear. There is no assumption around increasing costs for inflation. I'm expecting that to bite as we move into the new financial year, but pay settlements have been agreed and funding allocated. and planned for. And from a non-pay point of view, a large chunk of our costs are on contract. So not expecting any major changes there. We're working through with colleagues and estates to understand the impact of energy pricing. The one big item that isn't in this plan that I need to flag to the board is that we are currently holding an annual leave accrual from the end of last financial year that totaled £1.9 million, so nearly 2 million, that we have not assumed is released in these numbers. So there's zero impact of that accrual in these numbers. We need to work with HR colleagues between now and year end to ensure we have appropriate evidence to justify an accrual at year end. And I'll take colleagues through, both performance and audit colleagues, through those changes as and when we work through them. It is a national issue that we're trying to work through, but clearly we need to have appropriate audit evidence to support that. And that's me done, Karen.
Thank you, John.
Any questions?
Yeah. Any questions for John before we move on? No? Okay.
No. Can I just add, Karen? So apologies. Where I think this has got us to as a trust is a better position than I had expected, given where we'd landed H1. I think it gives us a window of opportunity to really focus attention on things we can improve as we move through the remainder of this financial year, be it around service change, efficiency, and wider planning. So I'm not expecting us to be in a position where we certainly were in H1, that we're going to have to focus relentlessly month in, month out on the detailed movements of the numbers. I think it's a credible plan. I think it's a plan that we've agreed the major assumptions with our system colleagues, and it should be deliverable. That gives us a window of kind of headspace over coming months, which I'll take board colleagues through in coming meetings. The plan to go about doing that, and the plan to make and maximise this opportunity. Thanks.
Thank you, John. Completely agree. Simon, I see you've got your hand up. We'll move on.
Just want to, firstly, actually, considering where we've come from, note the way in which senior finance colleagues are now working together across the system. For those of you who've been around Northampton for a while, I'm looking at you, Trevor Shipman, amongst others, you'll know that we haven't always been in the happiest place around this. And the work that John is doing with his system finance colleagues, I think, is to be commended. And I'd just like to note that for the board, because it is a welcome departure and improvement on how things have been historically. So well done, John and team. The other thing I wanted to say was to really endorse the comment about we've got a precious opportunity. We are not going to be spending the next few months scrabbling around chasing pennies to get to land ourselves in a particular spot on the runway. Therefore, the discussions that we have this afternoon on some of the transformation activities that we should be putting in place are really, really important, because they are the things that will help position us to enter next year, which is a more stringent air to it, in the best place that we possibly can. Thanks.
Thank you. Faye, shall I hand over to you to talk about the activity plan? Thank you.
Yes, thank you, Karen. So as part of the H2 plans, we're expected to deliver some specific performance indicators. And there are 4 which we will absolutely continue to achieve, which includes 52-week breaches and not having any patients waiting 104 weeks. And I'm pleased to say that across the group, we don't have patients in that position. So we plan to continue in that vein. In terms of cancer, again, we're expected to continue to deliver the cancer target as we did in February 2020, and also to continue to maintain current activity levels through our outpatient setting. We're also expected started to deliver some transformation within outpatients, and that includes patient-initiated follow-ups. And again, as an organisation, we are doing pretty well. There are two things that we are not able to deliver, which is in terms of stabilisation of the waiting list, as we've continued to see increased numbers of patients that are coming through, and also to achieve the completed RTT pathway threshold, as we did in 2019 and 20. I think it's fair to say that this is a realistic plan, and we will continue to push more and more as we can through our efficiency programme. Obviously, this plan is not without risk. We've got winter looming, and we know the pressures that we're currently under. We also know that our theatres are very pressured in terms of our staffing. It's a national problem. We're working with the teams to see what we can do around that. And obviously COVID with the additional pressures that brings. From a non-elective point of view, we've spent some considerable time going through our winter plan, which came to board last time. And as you may recall, we talked about likely scenario, which is what we've based our capacity on. Again, this is not without risk. We know that we have a deficit in bed capacity. That said, we've also got some additional beds that have come online to assist us with that, and a number of other schemes that we're working with the teams to mitigate that bed gap, which are doing really well actually at this current time. We also talked earlier about the work that we need to do with our partners, which will also help us deliver our H2 plan as we go through winter. The other good news to just draw to the board's attention is the fact that we've been allocated some targeted investment fund from the centre, which enables us to develop some transformational programmes, particularly in outpatients and other digital programmes, which will help deliver our activity over the forthcoming months. And I'm sure Andy will be able to give us a little bit more detail around those programmes of work. So I'll pause there. Thank you, Karen.
Thank you, Faye. Any questions for Faye?
Karen?
Oh, sorry. Hello. Yes, Lisa. Thank you. Hello.
I've got to set the context. Faye, you said that we're unable to stabilise the waiting list because we're still seeing an increased run rate, more people than we would have expected in a similar year coming in. Are we doing any work on assessing? This is where it gets complicated in my head. Because we had referrals stopped for a number of months, and I'm going to take a figure, say that was 1,000 referrals we were missing. Are we now doing any analysis of whether the run rate has exceeded that backlog and actually we're seeing increased demand on top of what would normally, or are we still just recovering the backlog? Did that make sense?
Yes, I'm not sure I can give you an exact number on that, but I think it's a combination of the two. But you're right to ask the question, and I'll certainly look at that. I think the important thing is that as part of the elective care programme, we're also looking at how can we manage that demand right at the beginning of the pathway. And that's something definitely the elective care board we're having a look and working with GP colleagues as well. But you're absolutely right to ask the question, and I will go back and have a look at those numbers.
Yeah, it's just because then the kind of locus of action changes. So we're actually seeing an increase in demand from general practice. It's a different view to, are we still catching up with the backlog, and therefore actually we can expect that to stabilise in the future.
Yeah, okay, yeah, I see what you mean. Yeah, absolutely. Okay, thanks.
Thank you. Trevor?
Yes, thank you. Is there, I can't see in the papers, is there any assumptions about, and the first group are those that are Northamptonshire patients that are on waiting lists outside Northamptonshire. So is there any assumptions about us taking on any of those patients? And then beyond that, are there any assumptions about us treating patients on waiting lists that are, again, outside Northamptonshire, but actually for residents outside Northamptonshire in this plan?
I'll deal with both of those if I might, Trevor. So both back to your point, Lisa, and also to deal with your point, Trevor. So on the first, this is one of the great imponderables of our current position. To what extent are we going to get bounce back demand from demand that was defrayed during the pandemic? And greater minds than I are still grappling, and ours are still grappling with that question. And the honest answer, Lisa, is nobody has yet come up with a definitive statement of what is going on. The point I wanted to make, though, was really one for transformation. Anticipating that we will get that demand, one of the key transformation programs that we will be asked nationally to engage upon is to create additional outpatient capacity by initiating far more assertively patient-initiated follow-ups, PIFU as it's known in the jargon, to prepare for the fact that the best available guess says that whatever percentage increase you put on it, we will expect to see demand increase over the next year. The difficulty is, and most pundits bet on the fact that that demand is going to increase. The difficulty is that we just don't know by how much and where. So I would encourage the board, particularly as we head into our transformation discussion this afternoon, to think about the outpatient element of it, because it will be that determines our ability to meet the demand and to release capacity. And we will be expected to engage in that, I think, pretty fully. On the point that you made, Trevor, no, it doesn't. But as colleagues will be aware, we are in discussions about how we might support some of our neighbours. I'm not yet in a position to finally update the board as to what those numbers look like, but we're getting close to it. I would expect through the December cycle of committees to be briefing board colleagues on the impact and likely number of what we may be asked to do to help others around us. So I would ask for indulgence today just on that, and expect to see it coming through finance and performance committees and the like in December, and thereon being reported in informal terms at January board. Thanks.
Thank you. Andy.
Thanks, Karen. I was just going to pick up on Faye's comment around the targeted investment fund. Just a brief summary. So we made 10 applications, of which 9 were accepted across our system. That's in the region of 10.7 million capital and 1 million revenue. All of that, the reason for those bids is to contribute to elective recovery, and each one of the schemes has got an impact on either the ordinary or follow-ups, and the expectation is that we'll have an impact of that in this financial year, but then the full year effect felt thereafter. And it's also worth, just as I finished, to say that those projections were built into the H2 planning that we've submitted.
Thank you, Andy. So there's no other questions. I'll hand over to Mark, but I mean, key is really around the discussion we've had so far is around how we can work over the next quarter, the next coming months, to build our plans for 22-23 and really focus on transformation and working across the system. But I'll hand over to Mark now for the people element of the plan. Thank you, Mark.
Thank you, Karen. Hopefully colleagues can hear me okay now. I've changed microphones and systems. So yes, the plan is as described earlier in our board development session at the beginning of this month. I think it's important to say that as part of the planning submission, obviously the first part of it was making sure that our health and wellbeing of our staff is maintained or improved as best as we possibly can be. We talked about this in a deep dive in our joint people committee in October, going through all of the work that we are undertaking and indeed the activities and initiatives that we're putting in place, including across the system as well as the hospital and the group. However, we appreciate and acknowledge that that is not having the impact on sickness absence rates as we have seen already in this morning's conversation with regards to our position as a trust and again across the group. So we know there is more that we can still do to help and support colleagues in our hospital and indeed across the system more widely. The plans that you see have been stress tested. So the workforce plans were stress tested in terms of I think there's a regular occurrence where every plan that's submitted in every year that I've been in this hospital, we see a growth in workforce, and we need to understand where that is occurring, what our feasibility of recruitment to that is, and the purpose of those new substantive posts that have been put into place. That the stress test has taken place again across the system, where we challenge each other as providers and across the commissioners as to that increase in workforce provision. And we believe that we do have good recruitment trajectories in place to recruit to those positions on a substantive basis, particularly that around nursing and healthcare assistants, which are articulated in the plan, but also earlier in the IGR in terms of our ever decreasing vacancy position that we see ourselves in. And as Karen says, that'll be really important as we move into 22-23 to make sure that we continue to look at any potential areas of workforce growth, whilst also taking into account the conversation earlier around the social care sector, and diversifying our roles and making them more attractive to people, because the labour market has changed around us and is ever changing around us, with other industries able to now offer increased salaries, but also development opportunities in a different way. I think it's fair to say in the health service, we've always been able to rest on the fact that we've been able to offer development and career opportunities. But I think it's fair that we continue to up our game in that area and to continue to review our offers for people in and around our county who wish to come and join us. Finally, I would also just like to point out on this particular item that we have agreed and communicated across both hospitals, and particularly in Kettering, the additional annual leave day for colleagues due to the impact and the reflection piece around COVID, for people to spend some time in terms of reflecting or to spend time with loved ones over that period of time. It's going to be really important we continue to look after each other over these next few months, given the difficulties that we know have already been described earlier in the conversation. I'll leave it there. Thank you very much, Karen.
Thank you, Mark. Any questions for Mark? Andy, is that a new hand?
Sorry, legacy hand, apologies.
No? Okay, I'll hand back to you. So this, as I said, this is plan, although we've already submitted for ratification of the submission made. Thank you.
Okay, thank you for that, Karen. I think the key to this is, John said it right at the start, really. It's a credible plan which doesn't involve us all spending endless amounts of time worrying about threepences. And it gives you space, gives you executive space and the board space to take decisions and implement things between now and the end of March that make the point we enter next financial year as good as possible. So that becomes a challenge about how to spend the capital, and to do that in line with the strategies we've agreed. As I was wont to say at the Northampton board, when a board agrees a strategy, it might be reasonable to expect something to happen as a result of that. And that means you should be making the decisions on spend linked tightly to the agreed strategies. So we look forward to seeing how that plays out over the next 4 months. Thank you very much, everybody. You've arrived at break time. Back at 12:10, please. Thank you very much. Okay, good to see everybody back. My computer says it's 12:10. University Hospitals North Hampshire Group Dedicated to Excellence 6-month review. Simon.
And also Alice, I think she is now back with us.
I am.
Great, Alice. So we're a bit of a double header today. I'm opening it out, and then Alice is going to conclude the discussion and then lead us into the kind of wider discussion. So rightly at this board, we spend time scrutinising our performance and looking at things that have troubled us or travail us. It's also important every so often to stand back and look at the bigger picture and see what we have done well and to reflect upon that, because the first thing I want to say, I suppose, today is despite the NHS having gone through one of its most difficult periods over the last 18 months, and that continued during the last 6 months, there is considerable progress to reflect on and to celebrate. You're going to hear 2 examples in the segment that follows, where there has been considerable delivery, one on the digital strategy, the other on the academic strategy, and I will not spoil the thunder of those presenters and let them speak for themselves. From me, just a couple of points then further. The first is if I could just orientate colleagues to slide 2 in your deck. You'll remember that we framed the triangle around dedicated to excellence, and the last 6 months has been about building progress across all of those different layers in the triangle. In our vision and mission, you will see today our clinical strategy. You will see for yourself the progress that we've made on our priorities. And we now have, via the CPC, a regular method, and indeed at this board, of reviewing our enabling strategies. The second thing I wanted to say was, we now, despite that good progress, we need to plan for the future. And so the second place I would commend people to spend a moment on is slide 13 of 14 in your pack, which really sets out our promises for further delivery over the next 6 months. I'm particularly pleased to be able to start reflecting on the fact that we will have joint swipe cards, joint ID cards that will allow us to start using the hospitals as though we belong to both of them. I'm equally pleased to be able to reflect on the fact that car parking will be part of that equation too. We all know that it's often not the big things that make the difference, but some of those small things taken together that really help turn people's minds to the future. But I'm also really pleased to be able to reflect on some of the aspirations we've got around patient food. Again, probably the thing that people comment most about, or one of the things that patients comment most about, is how they get fed when they're with us. And some of the plans around digital food ordering and what that will mean, not just for our sustainability agenda, we touched on that earlier, but also for the experience that patients have as basic a need as eating, I think are really exciting and give us big opportunities for the future. So with that, I will hand over to Alice. I just want to say, I think the CPC has been integral to the process of starting to review progress. Really important it is for our kind of joint narrative and building a narrative across the group. And I'd like to take the opportunity of thanking Alice and Rachel for their leadership of that committee over the last 6 months. And with that, I'll hand over to you, Alice.
Thank you, Simon. Yeah, I'd agree. It's been a really good group to be part of. And I sort of reiterate the invitation, particularly to NEDs who aren't always able to come to all of these meetings, I know, but please come along, because it's really been a good way of us all getting our heads around everything that we've got to do. So I just wanted to draw your attention, I guess, to some of the themes coming out of slide 14, if those of you who've got your packs in front of you, of the slides for this agenda item. So myself and Rachel and Becky put our heads together and sort of said, well, what are we really pleased about for the last 6 months? And what concerns us about the next 6 months plus, if you like, and what do we really need to tackle? And I think we were both all pleasantly surprised when we looked back that although there have been frustrations and in areas progress has been frustratingly slow, in a lot of other areas we've actually made really good first solid foundation steps. So the achievement of the university hospital status, in some ways it doesn't sound too significant, but it's actually the bedrock of a lot of what we want to do, and I think is starting to make people feel like we have a brand for us as a group rather than the 2 individual hospitals. So has been a really significant achievement. And in some certain targeted areas, we've started to make collaboration a real prospect in our group of hospitals. And we saw with the patient story last time how we can really make some key differences to patients in some the 3 key areas where we've started to collaborate in a meaningful way. And I think for me, whilst the progress in those areas has been mixed and we've achieved more in some areas and less in others, and it's taught us a lot about the challenges, the pleasing thing I think both myself and Rachel reflected on was that in a lot of areas, the clinicians and the clinical staff of all types are saying to us, we want more and we want to go further. Now we've seen a little bit of what we could do. And I think that is still to be tested in some areas, but on the whole, we found that really pleasing that although there's challenges, on the whole, when people start to collaborate, they are saying, hang on, I'd like to do more of this. So that's really encouraging. And I think we'd like to give more people across the organisations a taste of what we can do to then open their eyes a little bit and broaden their horizons and make them more ambitious about what we can do together. I think we've got some really good solid work in our enabling strategies, the digital, the academic, the clinical, that we're going to talk about later today. And those get some of, again, the base in place for the clinical collaboration we want in place. And ICANN as well. We haven't heard much about ICANN, I know, for a while, but it's quite a landmark in terms of what we've agreed to do. And therefore, I think that's a really good landmark of these last six plus months, if you like. So that was our sort of feedback on what's gone well so far. In terms of looking forward, though, we had some sort of challenges or questions for us and for all of you, I guess, and for all of the people who work in our hospitals. So I'll come to the first one last, actually, because I think that's sort of almost the closing question, if you like. But how do we start to culturally feel more comfortable with change? So that goes back to how do we get over some of those things which have been frustrations in the last 6 months in a few key areas where we've tried to collaborate. They've often not been huge issues in some ways. They've been little bits of culture where we rub up against each other as 2 teams in a way that doesn't always work smoothly. So how do we get people more okay with change? And I think that also links back to what we heard earlier with the Never event story around being comfortable with challenge, being comfortable with thinking about what we do and thinking why we do it and what might have gone wrong, and learning and changing and developing as well. We particularly have an opportunity with the Outpatients project to accelerate that, and how do we best support that, give that the best chance of being really game changing for us. And how do we support the clinical strategy as well, which I think is going to be the key way we then roll on what we've done in the last 6 months into the future to make a difference for our patients and our staff. How do we support the work that Matt and Rabia have done to go to the next stage, to the real implementation stage? And then I guess finally, how do we do all of that, maybe a little bit further, maybe a little bit faster in some areas? And what risks are we prepared to take? And what risks are we not prepared to take? What's our risk appetite, if you like, for doing all of this? And I'd welcome, I guess, any reflections from all of you on whether you agree with those conclusions that we've got to so far, and what you think the key things are that we could do for the going forward period to change the dial a little bit further and push everybody to be a little bit braver as we go forward together. So would welcome any reflections or questions.
Trevor.
I think, thank you very much, Alice. I think one for me, and it goes back to the change point, and it's allowing the space for people to accept that challenging change is acceptable, that actually you can challenge it, and that we've got processes in place for that. Because I think part of the cultural issue, not just between these two hospitals, but more generally, is people feel uncomfortable about putting their head above the parapet. And sometimes that friction arises not because there are major issues, but just because of their sort of level of being uncomfortable with it and not wanting to say that because they feel that they will be left out somehow down the sort of scheme of things. I suppose that was my first reflection. Second reflection is I think we need to allow enough space for that external focus. So yes, we need to focus in, and you mentioned ICANN, that's probably a good branch across, but I think there's others where we're not just focusing on what University Hospital, Northamptonshire hospitals are doing, but actually what is it we're doing in Northamptonshire. Sorry, I got the words around the wrong way there. What are we doing in Northamptonshire? And so one of my challenges, and I sort of thought I'd raise it earlier, but this is probably a better place, is if the key issue in delivering care over not just the next winter period, but going forward, is around social care, actually how much in our gift is to do something different, maybe in place of something we're doing in the university hospitals, because this particular agenda item is so major that actually it will trip up everything else we do.
Okay, Suganya.
Thanks, Alice. I'm really excited about this piece of work, and it's a massive piece of work. And I totally agree with you. It's having that courage and also the compassion and the empathy to understand where the clinicians are coming from. And what I have identified in the last few months after being here is the team are just held behind by the beliefs from the past, but just breaking that is going to be the biggest barrier for us. But keeping that momentum going as senior clinical leaders and getting to their level to understand, to say, you're not going to be, you're going to be heard, and we're actually acting on your, in your best interest. I know probably we are doing that, but just keeping that constantly reiterating to them probably is the key, at least from gynae strategy point of view, where I have had a more exposure to that. Is a thought I would like to share. Thank you.
Thanks, Suganya. And I know, sorry, Alan, if I might just quickly respond to that, that I think also perhaps some of those beliefs from the past, we need to sort of name them in the room almost sometimes, and they're almost unsaid a lot of the time, and it will be helpful to name them sometimes, I think.
Yeah, I agree. Lisa.
Thank you. Look, for me, when I sit back and I look at the deck as filed, I think it's quite incredible how much we have actually managed to achieve over the last 12 months, right? I know we've been kept abreast of a lot of these initiatives as small pieces, but I think seeing them all here as one, I think deserves a moment of reflection, just to congratulate the progress that we've made despite the challenging times and the operational pressures that we've alluded to as part of the IGR. For me, the culturally, how do we go faster, further? Completely agree with the sentiment, because as Simon alluded to early on, the need for change is greater than ever. But I also think, the underlying desire for change is greater than we give it credit for as well. And I think, you said that when people actually experience it for themselves and the benefits, they are coming on board. So I suppose I just encourage us not to limit our own thinking about what we can achieve and how fast we can run, because if anything, the last 6 months has shown us we can do more than we believe we can.
Yeah, I think I'd agree with that. I think, first of all, I can join with Simon in saying I think the CPC, the Collaboration Programme Committee, has done a really good job. And that's congratulations to everybody who's been involved, obviously Rachel and Alice, but I mean, the actual secretarial support and all the things that make it happen have been very, very effective. For a brand new committee trying to do something brand new is pretty good. I think too, you're right, Lisa, the desire of people to do this will grow. And it will grow particularly if we spend money on things that are part of our strategy. In other words, if there's seen to be a continuous thread through this that says the board sets these strategies, of which we spent a lot of time agreeing them. Some people got quite frustrated about the amount of time we were doing, but having set them, we were very clear we weren't going to change them. And so now, as we start to make decisions about capital or about revenue, or about new staff or whatever, then the linkage must be incredibly strong to those strategies so that people, when they look back and say, okay, I understand the thread, I understand the logic, I understand the fact that this was not trivial conversation, these were important things. And then effectively, as a friend of mine always used to say, herding cats is far easier if you put a tin of tuna in the middle of the table. And the spend and investment pattern is the tin of tuna in the middle of the table. So anything else you guys want to say, Simon, Alice, or anybody else for that matter? No? Nope. Okay, look, I think it's a really good report. I did, after the Northampton board where this came up, I did sit and think to myself, it's a bit self-congratulatory, all this stuff. We've had quite a bit this morning. It feels a bit like that. And it wasn't meant to be like that as an exercise, but it is an interesting reflection. And Alice said it, and Lisa said it, you know, a lot has been achieved. Still a lot to be done, but a lot has been achieved. And some of the biggest questions sit in the integrated care system, but we've still got a lot to answer ourselves. And that's stuff that's coming up as we go forward. Okay, thank you very much, everybody. That was a good conversation. Now, group clinical ambitions towards our clinical strategy. It's going to be led by Rabia with Polly and I think Matt, but I don't, oh yes, there he is, Matt. So over to you, Rabia. Thank you. And your microphone's still open, Lisa, I think. Oh no, you're off now. Thank you.
Thank you, Chair. Hi, everybody. Really excited to present on behalf of all our clinicians across the group, our clinical ambition towards our clinical strategy. So we've talked about dedicated to excellence strategy earlier on. And if you remember that triangle, clinical strategy sits at the heart of it, synergizing with all the other enabling strategies. But before we say anything, I'm just going to join Simon and thank everybody who has been responsible in getting our clinical ambition to this stage, involving all the clinicians, but in particular, I would like to thank Polly, capturing all the thoughts and getting everyone together in various forms and shapes. Couldn't have been easier, Polly, but you did an amazing job. So thank you very much for putting it all together. It involved 7 months of extensive engagement with hundreds of staff across both organizations, and Matt is going to talk about that in a little while. Mainly, but not exclusively, clinicians. So it did reflects the voice and views of both our organizations. We also invited East Midlands Senate to review on our ambition, and the feedback was largely positive. However, they did offer some constructive challenge, which was very welcome, mainly around the leadership and management framework when we are working collaboratively, but also ensuring that there is absolute system integration, and like Trevor said, externally focused, because it was felt at the stage when the ambition was reviewed, it was mainly focusing internally, but it has evolved since. So I'm going to try and summarize 126 pages of what I think is a landmark ambition document. I will in fact call it a landmark moment. And I think the reason why I think that's what it is, but it has moved us from historical position of competition to building on opportunities to collaborate, and that with keeping the patient in the middle, how we can enhance the quality and safety, but also experience of our staff and our patient. And for me, Alice, it has been at the start of that journey, which you talk about, the culture change, and is a key to change. And whether it was a cricket match that we did together, or yesterday we had an open live session to talk about prostate cancer, with our specialists from both the trusts who were participating, the urologist, and it was amazing. And to see that start of collaboration in practical term, not just on paper, was really very heartwarming. But at the same time, we do appreciate that it is really, really crucial to have our patients and all our stakeholders involved. And Polly's going to talk about that in next steps. But we have seen with Bernadette's story and today with Mr. Toop's story, how valuable our patients' direct feedback is. And when I say direct feedback, I mean having patients as co-founders. And that's what we will be hoping to do moving forward. We are already collaborating in some of our services, as you would know, stroke service, renal service, heart attack out of hours. But what we aim to achieve with formal collaboration is that acceleration, which everyone has talked about since morning, that formal collaboration is bound to accelerate improvement and innovation. And that's what we really need. So this document sets out a framework for our collaboration moving forward, which will be capitalizing on our strengths, addressing the gaps and challenges we have, and working together with our system partners. To do that, we will be co-locating services where the evidence suggests it's best for the patients and our staff, but at the same time, trying to see how we can deliver services in the communities closer to patients' home on both the sides. We know we have a compelling case for change, as shown in the section 2 of the document, which was shared earlier. We do offer some exemplar services between the two trusts, and we are really proud of that. But unfortunately, across the county, there is variation in that high quality is not offered to everybody. And that's what we want to address with our collaboration. There is inequity and variation in waiting times and diagnosis and treatments. And at the same time, we do have challenges with recruitment and retention of staff. We do remember from Bernadette's story, her experience through that fragmented clinical ENT service across the county, which now have moved on and changed. And we have actually started seeing the benefits of it in patient experience, but also in challenges which the staffing in the ENT service faces. So again, coming back to what Alice, you were mentioning with regards to seeing those real examples coming to life is actually pushing everyone to want more and do it sooner. And we also know that the predictions of future demographics of our county are not in our favor, and we need to do something to be able to sustain our services to help deliver high quality service to our county. And also the recovery following the pandemic has its own challenges. So our clinical ambition, as it was shared with all of you, you would have noted, is focused around 4 main areas. Firstly, it's developing centers of excellence in the county. And the centers of excellence, as we see, will be national exemplars, attracting academic and clinical talent with best practice clinical care available for our patients across the county. Center of excellence will be transforming services to enhance quality of care, not about acute hospitals, but focusing on integration, prevention, and care in the community as well. Initially, our clinicians have set out plans for 2 centers of excellence, one being cardiology in Kettering General Hospital with cardiac MRI and other non-invasive imagings and minimal invasive cardiac interventions, offering state-of-the-art service to whole of Northamptonshire, and having a cancer center of excellence in Northampton General Hospital with radiotherapy and robotic surgery. And like I said, it was really great being part of that Q&A yesterday where urology specialist were talking about prostate cancer as prostate cancer awareness in support of Movember. So our clinicians are really coming together, seeing where there is benefit for the patients. Secondly, we would want to protect elective capacity because we know that emergency pressures are inevitable, even though we've got one of the best elective lists in the country, but we want to not only sustain it, but to improve it. And to do that, we need to be focusing on how we can do that collectively across the both organizations, focusing on elective hubs. Thirdly, we also have some really struggling specialties, which are handful, but they are there with their challenges, and those services are almost unsustainable and fragile because small number of workforce, national shortages, difficulty in recruitment and retention, and then that inevitably affect the quality of service we deliver. And lastly, but not the least, is working alongside with all our health and care partners to deliver seamless pathways. Unfortunately, our patients experience disjointed pathways when they have to move between primary care, community, acute hospitals, and we really want to address that working with our system partners. Currently, we've agreed on 4 priority areas with our system partners: frailty, children and young people, elective care, and mental health included in them. And together, we can certainly strengthen those services and experiences of our community. As I mentioned in the start of our discussion here today, is the clinical strategy will synergize with other enabling strategy to deliver dedicated to excellence. And even though firstly we have pointed out certain priority areas, but as we mentioned earlier on, our clinicians are now wanting more and more when they are actually seeing the benefit. So it's not stopping here. Our work to refine and develop our collaboration will continue throughout the next year as well. I'm going to ask Matt to talk about the engagement we had in developing this strategy, if that's fine, Matt.
Thank you, Rabia. Thank you, Chair, and thank you, colleagues. It's a great pleasure to be invited to join your board meeting to discuss this clinical ambition. And I'd like to start by saying that Rabia and I are both really proud of our clinical leaders across both hospitals for the work that they have done to get us to this point. Because, as Rabia said earlier, we'll be setting out for you the extent to which they have led the development of this clinical ambition. And this work did indeed start right back in April. The first phase of the work was run from April to July of this year. And alongside the all staff survey, which Rabia has already referenced, where we had many hundreds of responses, overwhelmingly positive about the opportunities to deliver better care for our patients by working together. We are both clinically led organisations, and it is our clinical leaders that have shaped and driven this strategy forwards. So in that April to July phase, the areas of a clinical strategy for ease of managing the work were chunked up into 5 pillars around emergency care, planned care, diagnostics, cancer, and women's and children's health. And those pillars were informed by data and analysis provided through a consultancy, but the models that were initially drafted were all clinically led and delivered. And this culminated in a first draft of the clinical ambition for our strategy, which was presented to a joint clinical senate across both Kettering and Northampton General Hospital. The Senate was attended by over 60 of our clinical leads. And when I say clinical, I'm deliberately being multi-professional. So we had our medical, nursing,
pharmacy, physiotherapists, midwives, etc., joined us, and they kicked the tires on the initial draft and came up with some really helpful suggestions, and opportunities for feedback for those who are unable to attend were also provided. And just to echo Rabia's comment, Polly did a beautiful job collating and theming and compiling those into the subsequent iterations of the strategy. And the next draft of the strategy was presented again to our clinical leaders at our next clinical senate across the group in September, where some of the design principles were retested and the principles used to manage interdependencies were also explored. And much further useful feedback was garnered and woven into the ever improving strategy. A seminal moment in the development of the strategy occurred at a face-to-face clinical conference on the 1st of October, where the level of ambition was really tested by our clinical leads, and a moment that will live long in the memory of most of us that attended, was when one of our clinical leaders asked us a pretty direct question, really, which was to the effect of, are we going to decide to build excellent care for the patients in the future, or continue to celebrate the successes of the past? That was quite a challenge, but Rabia and I like a challenge, so the challenge was accepted, and we lifted the level of ambition to up a notch. And as Rabia has already referenced, but it's worth dwelling on just a little bit longer, in order to make sure that we were not running away with ourselves or being too limited in our level of ambition. We did share the draft Senate report, the draft strategy document with the East Midlands Clinical Senate. Now, just to expand on what that means a little, that's 56 clinical leaders, senior clinical leaders who are elected to that Senate across the East and West Midlands, who provided extensive feedback, and overwhelmingly that was positive, and in particularly appreciative of the level of ambition and the work that had been put into the developing the strategy, with some helpful suggestions on how we might build further in next steps, for example, with the emerging integrated care system, and I know Polly will touch on that shortly. So with the benefit of all that internal and external reference, a further iteration of the strategy was presented earlier this month to, again, a third joint group clinical senate, before we have set this current clinical ambitions document before boards this month. And so what I'm commending to the board is that there has been extensive clinical engagement and design of this clinical ambition towards our strategy document. And whilst no democracy is perfect, this has been a very democratic process, and this clinical ambition is very much set out to you by our clinicians and for our patients. Thank you.
Thank you, Matt. Polly, should we just talk about some next steps?
Yeah, happy to, Rabia, happy to. So yeah, in terms of next steps, there's 4 key things really that we'll be looking to do over the last quarter of the year. So the first of those is to test what we think. So this document, as the 2 medical directors have said, sets out what our senior clinical leaders think, sets out our ambition, but we need to test that. We need to test it with our ICS stakeholders. Have we got the right level of ambition? Could we go further with some integrated pathways? We also need to test it with our patients. As Rabia helpfully said, we've had really good feedback from our patients in other areas. So we want to listen to them about what they think, and hopefully the culmination of that will help us refine this document further over the next few months and make it into a strategy at the end of that. So the detail of exactly how we're going to do that will take place over January to March, and we'll be setting out the detail of exactly what that's going to look like in the next couple of weeks. The other way we're going to test it is we're going to start to do some more detailed planning on it. So we've talked about centres of excellence. What we need to start to do is actually have a look at some of the pathways and pathway improvements that we've set out in the document and start to do some demand mapping. What's the demand going to be on us, on our system partners over the next 10 years? And really then, what's the capacity we need and the resources we need to be able to deliver that over the next 10 years? So we'll be able to see, are we being realistic in what we're setting out? Are we being, and what are we going to need to do to deliver our ambition? So as a result of that, we'll have some full capacity and demand and site-based strategies, and those are going to tie into then one of the other key enabling strategies, which is the group estate strategy. So that will start to be launched in April as a direct result of this clinical strategy. So that will start to take place. The second area that we're going to have a look at over the next few months is our fragile services. So as Rabia set out, we've identified as part of this process where we think our fragile services are across the group. What we haven't done in this document is worked out what our solutions to those are. So we'll be working with our system partners, not just inside the county, but also externally with some of our tertiary providers and other regional colleagues to work out how can we really build sustainability in some of those fragile services for the future for our local patients. Third area, and this has been referenced a few times, and what we're finding is as we've gone through this process and we've done the clinical collaboration, as Alice was referring to, there's many more clinical leads that have come forward and said, well, we want to get involved with this, we want to start talking to each other, we want to start taking forward our collaboration, and that's brilliant. And we need to provide them with a clear framework as to how they can do that and safely get on and do that amongst themselves. Things like what level of patient engagement and how and when to do that, those things that will keep those kind of conversations happening in the right way. So we'll start to work on that framework for clinical collaboration. And the fourth area is the tin of tuna that Chairman you were referring to. So we've set out in this document some key areas where we think we need to put some investment as a priority. We've set out that will probably be on the cardiac MRI and the specialist cancer robot to help support our centres of excellence and the head and neck estate over at Northampton as well. So actually over Q4, I'll be working with John and the finance team and the operational teams to work up due diligent investment cases on those so we can start to really from April, once we've signed off the final strategy following engagement, we can really be on the front foot of moving ahead and getting those implemented as soon as possible, because that will start to show to our senior clinical teams that we mean what we say. So that comprises the next steps. Rabia, shall I hand back to you?
Thank you, Polly, and thank you, Matt. Chair, that's from us, so I'm happy to take any comments.
Okay, thanks, Rabia. I'm sure there will be some comments on that. I think it's important to emphasise this is the opinion of our clinicians. Whilst the board has seen it in bits and bobs, it's the first time you've seen the whole argument. So I'm sure there will be comments on this. I think the other thing to say is, we must be humble enough to know that when this goes out, there will be people who argue with it, and we must be prepared to alter it in the light of the comments we receive from patients and from partners and from others. And that's tricky because we also want to press ahead with some of the issues in it. So the balance of presumption versus humility is going to be quite a tricky one. And we must make sure that we mean it when we say we're going to talk to patients, staff, wider groups of staff, partners, other agencies, and all the rest of it. So welcome your comments now, or questions or challenges on this. Alice.
Thank you, and thank you both. And I'm aware of all the work that's gone into this, and also it's been a pleasure actually to attend the clinical conferences and hear what the clinicians are saying about this. So thank you for including us in that. My sort of reflection was around what we mean by a centre of excellence, and have we really bottomed out in our heads what that is and what it means to our clinical teams and what it means and how we're going to communicate it to our patients. the reason I sort of ask that is when I read through this document, I think I know what we mean. And then in different places, we describe it in slightly different ways. And we say things like no duplication of complex procedures at either site, which makes me think the patient's going to do a lot of travelling and the staff aren't going to do any travelling. And sort of things like that come out and you start thinking, and I guess that is also what's going to come out when patients start hearing about this and other staff start hearing about this, that are we going to have a poor relation site at the other place? What are we going to do? What is our model of what a centre of excellence means, and are we clear about how we're going to communicate that to our patients, I guess, was my reflection.
Okay, thanks. Going to gather some thoughts here. Damien and then Janet.
Thanks, Alan. So I had two questions. One was around the scale of ambition. So it's really a question for Matt and Rabia. If we said that, say, 5 is the most ambitious this could be on a scale of 1 to 5, where would you put this, out of curiosity? The second question was a bit more of a practical one, which again, about the centres of excellence. It makes reference to attracting leading experts in the field. And I just wondered what the thinking around that was in practical terms. Is it that you have to build these centres of excellence and that is what will attract these leading experts? Or is it that you want to engage the leading experts to help design the centres of excellence in the first place? So two questions, one on the scale of ambition and the second one on specifically how we get leading experts into the centres of excellence.
Okay, thanks, Damien. We'll hold that as well. Janet and then Trevor. Janet, you're muted, I think.
Thank you. Apologies for that. So following on from Damien, there's clearly got to be competition for these leading edge individuals from the surrounding university hospitals. I'd be interested to know how we would set ourselves apart in order to offer a greater opportunity to come here rather than there, for example. And then the second question is around communication. The document itself is great for us to read, but my concern is that for members of the general public who don't have perhaps experience of either working or being involved with the trust may find the document hard to read and to understand. So what plans have you got to ensure that you do something that makes communication easier for engagement? Thank you.
Trevor and then Edmund.
Thank you for the document. It's and we've heard lots of bits of this along the way, and it's not, it has built into quite a substantial piece of work here. I think that one of the aspects of this is how are we going to test some of the feedback that we're going to get over the next period in terms of how will our centre of excellence, how will our strategy benefit from that feedback, given that we've got a population that we haven't consulted on this. We haven't consulted a lot of our workforce on this. So how is it we are going to test their feedback so that we can still continue having what we want, but actually it delivers what they want and need? And part of that could be actually, where are the major health needs of the population encapsulated in our strategy? Some of it is, but actually, as was referred to earlier, the actual mapping of our population, we haven't gone through that. So how and when we do that may impact on what it is that we say we need to do going forward, and how do we test that in our sector of excellence? Sorry, and finally, how do we test if there's something we shouldn't do? So it's good that we say, oh, we want to be best at this and best at that, but actually, are there certain specialties where we say to our clinicians, yes, you are very good, but actually we shouldn't be doing this by ourselves in Northamptonshire. The demography and the population says that this should be done on a East Midlands basis, not on a Northamptonshire basis. Thank you.
Okay, thanks for that, Trevor. Edmund and Chris. Edmund, you're still muted.
Sorry, thanks, Alan. Yeah, so thank you. This is really interesting, and what I'm going to ask has been partially touched on in earlier comments, but I would welcome your view on how this will be communicated to the general public, and what does it mean for the general public. So we talk about excellence, we talk about improvements, but I think we ought to think about how we can, well, I'd welcome your views on how we can get across the messages to our stakeholders, to our patients.
Yeah, okay, I think there's a theme coming through this. Chris.
Thank you. As you can imagine, I've seen one or two clinical strategies over the years. I thought the development of this was really, really good with all the various inputs. But having now just read through the document, I've come to two things, a suggestion and a question. The suggestion is, can we have the 1 minute version? Because if someone asked me after 125 pages, what's the 1 minute version? I haven't got it in my head. And the second, my question is, what do we see as the UHN role in reducing health inequalities across Northamptonshire, when the inequalities are largely arising from social issues? Do we have any part to play in that? And equality of access comes up in the document. If you're really seriously deprived in a deprived area, equality of access may mean having bespoke transport facilities available to you. Rather long question, but that's where I'm heading with it at the moment. And it links to Edmund's question about the public perception of it.
Lisa, surprisingly enough.
Somebody mentions inequalities and I have to speak. Just to start with, a huge amount of work. Congratulations to everybody. So please take any comments as add-ons. Support Trevor's point in that actually, how are we going to stop some of the service developments becoming shopping lists and actually gain assurance to the board that we have the volume, the quality, and the need to do some of these service developments. There are a couple of areas that just feel a bit like shopping lists at the moment. And I think that's where they're they weren't involved right at the start. Second question was around, or second comment was around actually the public facing and the engagement with the local authorities, as well as the general public, and whether we have a view that they see any of this as major service change and requiring consultation, but I might be using old terminology there. And the third thing was, how does this link in with the ICS ambitions, which then goes back to the inequalities, because we have mentioned it, but we kind of haven't joined up the start to the finish. So I'd really like us to think about how the document develops when we start looking at the elective pathway across ICS and the non-elective, etc., and really looking at those inequalities.
Okay, any other comment at all? No, Chris, you've got a legacy hand still up. Okay, you want to respond to that, Rabia?
I can try, Chair. So I'm just going to theme the questions up into 4, if that's okay, 3 or 4, so we can all contribute, myself, Matt, and Polly. So one theme which came out quite loudly and rightly so is about communication or engagement with stakeholders, patients in particular, and how we're going to do it, in what form we're going to do it, and when we're going to do it. And the other one is around center of excellence, what does that really mean? And is that something static, or is it going to evolve, and what will it look like? And the third one was integration with system, and the extent of it, which is not very clear at the moment. And I think there was one other question on the scale of ambition on 0 to 5. And I think that question, Damien, you asked. And so I hope I've kind of covered the themes. I'm going to start off with Damien's question, and then I'll bring in Matt on where I put it on scale of 0 to 5, the ambition. And so for me, Damien, it has actually fluctuated, if you're asking personally, because if I keep in mind where culturally and in hearts and minds the two organizations were, like I said in my presentation, from historical position of competition, I think where they have come now is 3.78 in terms of really wanting to come together and work and collaborate, and we are seeing that change. But if you look at certain specialties who are already collaborating, so it's all I'm trying to say is it's very optimistic. It's very hard to put a number on it. I think it's ambitious enough, considering where we are, but it certainly can be pushed and challenged, which is happening as we speak. Matt, your views on that?
Thank you. I thought the questions and comments were really insightful and helpful. So first thing to say, and as Rabia has invited me in on the level of ambition, I thought it was a really interesting question. I couldn't do it to 2 decimal places like Rabia. I'm simply not precise and scientific, but I would probably give it a 4. At the moment, I would also definitely agree that that level of ambition has been built. And what's been particularly pleasing is that the ambition for our patients has been stretched by our clinicians, and I think that's the right way round. The reason I'm giving it a 4 and not a 5 is I think, Elisa touched upon it, and many of the other questions have really been in the territory of next steps, so around engagement with patients, population, and with other stakeholders in the system. And those would largely be my answer to those questions. But I think that I would love to stretch the ambition towards a 5 to looking at options for synergies and reconfiguration of services. But that's not just our clinical leaders and our existing patients that we need to take with us for that. That is a broader consultation, and that's what would, for me, Damien, would take us from a 4 to 5. Always looking to be more ambitious. If I may, Chair, I thought that Alice's question around what constitutes excellence was a really helpful one to alight on briefly. There is some detail at individual service or centre of excellence level on the pages of the strategy, and I shan't seek to recapitulate those here, but I think an overarching principle to drive excellence that is links to Lisa's question and the level of ambition would be that I would see this document takes us helpfully in the direction of consolidating into hospitals, or even one hospital, where that is what is necessary to maintain or drive up further the quality of clinical care. And equally, and in relation to the ICS and other stakeholder question, which has been very helpfully raised, the opportunity where the quality of care and outcomes are not compromised, to disperse the delivery of care into the community, into diagnostic and minor treatment hubs, etc. That will, of course, improve experience and convenience. And to Trevor's question, it will also address social deprivation and access to care, the more that we are able to do that. And forgive me, I forget who asked the question. I did a lot of scribbling, but I didn't write enough names down, so apologies for that. But how are we going to attract candidates in Janet, I think it may well have been you. How are we going to attract candidates when we have competition from surrounding tertiary centres, etc.? And I think the
for me, we know that the national backdrop in terms of availability of clinicians, certainly in some specialities, is a really tough market for hospitals to recruit and attract into. That emphasis change, that balance changes in the favour of hospitals that offer more interesting career portfolios, particularly those, for example, that include the opportunities to participate in research, innovation and education, hence the academic strategy of which I know you are going to hear more shortly. And yes, there are other surrounding tertiary centres that can also offer more exciting clinical portfolios and diverse job plans. But we don't see them as necessarily competition. We see them as partners as we take our steps into this journey. So, for example, we are, I don't want to steal Kay Faulkner's thunder, but we are very much in partnership in some large-scale bids with the University of Leicester and University Hospitals of Leicester around clinical research facilities and NIHR biomedical research centres. So those were my thoughts. The feedback was really helpful, and much of it was forward-facing in terms of next step, which I know Polly may well want to come in on. But those would be in terms of the bits of where we are now, how I hope that those have been helpful answers to the questions raised.
Thank you, Matt. One of the comment which pretty much everybody brought in, and it was really useful, is around patient feedback and how we're going to deal with it. So firstly, thank you very much for all those comments, because I think even though they were all about patient feedback, they were coming from different angles. So it certainly has made us think a lot on how we're going to approach that. What I can share with all of you is that we've developed patient engagement model with the help of Rachel and James from patient experience teams, both in Northampton and Kettering respectively. Don't think James is here. That patient experience model is something which we tried on patient engagement for ENT services, and it's quite an elaborate model. But what that really involves is that testing the whole document with the patient. So what our next steps would be is sharing the information with the help of James, with our patient groups, and getting the first impression from them is how they want to change and reform. And I think, as we said earlier on, we're absolutely willing to change or shape it when we are sharing it, prior to sharing it with our patients, and make it to be presentable to the patients and understandable to them. Because that what patient engagement model does is it is based on data, but the language it uses in communication is what our stakeholders and patient wants. So we will be using that. Polly, do you want to come in on next steps? And
I can do. I wonder if Teresa has got her hand up, though, rather to come in directly on the patient engagement and the stakeholder engagement. Teresa, did you want to go first, and then I'll follow up?
Thank you, Polly. So there has been a lot of work undertaken on an engagement strategy that I'm building out with Polly and Simon. And we really initially look at making sure that we're engaging with our local stakeholders, because, as mentioned, we need to make sure that we get the local politicians on side with this. And then we have, having built the plan the way it is, it's very easy to break it up into easily digestible chunks, which means we can take aspects, so the bit that relates to, say, cancer services, we can take that and we can put it into a really easily digestible form for patients and the wider community. And this is a piece of work that myself and my team will be building out as we move into the new year. We have to be careful, though, because we're very interested in this and we're finding it all very exciting. But for our patients, they're just going to want to know, what does this mean for me? Do I have to travel? What are my services going to be? So we make sure that we're going to have to pull out the key messages that are going to be important to our patients, not necessarily what are going to be important to us. So it will go into a much more digestive, smaller, condensed form, which will basically pull out the bits that are important to our customers. We have a number of channels we can use to get this through to our patients. We can use press releases. That's a very difficult route to use, because then we're going to be putting ourselves at the mercy of the media and how they want to display the story. But we'll also be looking at how we can engage with our social media channels and also our patient forums as well. And we'll make sure that we engage and that we look at the feedback as well. So social media is a great opportunity for seeing how people are responding to messages. So we'll make sure that we monitor all that as well. And the way the plan has been built, the communications plan, it has feedback built into it. So nothing is set in stone. And as we go through communicating this to our stakeholders and our audiences, we can make sure that we're taking on board the feedback and making sure the plan is adaptable as we go through it. I hope that reassures some of the concerns there were about communications, but I'm very happy to take any more points on this.
Thanks, Teresa. As predicted, a much better and more thorough answer than I could ever possibly give on that. I guess I put my hand up because I thought, well, I'll pick up any last questions that I don't think probably between the two medical directors and Teresa we've answered. So the one I'll pick up is probably around some of the comments about the centres of excellence, and are we really clear on what services are moving where and what the impact will be on patients and how we might support those patients and any specific impact on health inequalities. And the answer to all of that is that's part of, so I talked about us our testing our plans and testing what we think and doing some of those more detailed planning over the next quarter with our stakeholders and with our patients. That's exactly what we will be doing as part of the next step, because just to reiterate the point, this is just a general direction of travel that we think, and we need to absolutely engage with all of those people and work up and what are the implications of that. Do we think that that's still the right thing in March, or do we not? So an answer to all of that, albeit there's really helpful comments because they're quite specific and we can make sure that we address those specifically, will be picked up in the next phase of work. And then the final one that, again, I referenced, but for a specific answer, Lise, I think it was you, in how do we make sure that this isn't a shopping list and how do we make sure that we're doing things in the right way? And again, just because there might be things set out in here in terms of investment, that does not at all excuse us from going through the normal routes of due diligence, business case testing, financial assessments, through all the same processes we would normally follow, equality impact assessments. There may or may not be, we don't know yet because we haven't defined exactly what our answers are, patient engagement or patient consultation and going to OSV committees and that kind of thing. So don't want to preclude the fact we might or might not need to do that, but we're just not in the place yet that we understand that, and that will be part of what we're doing over the next 3 months. So those were just the last few questions that I think people raised that hadn't been answered by any of my colleagues.
Okay, thanks. Edmund and then Simon, please.
Thanks. In terms of communicating to the public, what would success look like in terms of hard quantifiable evidence? This has been a successful strategy. What would it look like?
Okay, let's just pause that one there. Simon.
So I just want to take colleagues back to firstly the case for change, if I might. So prior to coming together as a group, both organisations published clinical strategies. Kettering, you will recall, those of you who were here, did so in about 2019. In the life before the pandemic, and Northampton did likewise. Both of them concluded the same thing, that staying as we were over the medium term was not an option. We needed to start sharing, start collaborating, and indeed some of those strategies and some of those thoughts that came from them were integral to forming as a group, us forming as a group. If anything, the pandemic has lensed and accelerated the need to respond to those strategies, those drivers rather. We've talked about them all this morning: workforce, service sustainability, the ability to reconcile the demand that we face with the funding that we have. So I hope that first thing that colleagues can accept is that staying as we are isn't going to be tenable. And I suspect that some of the challenges that we face will require us to act sooner rather than later. I think that case for change then leads me on to, so what do I think of where we've got to? I think we've already got the building blocks of established centres of excellence in the county. We already have cancer care centralising at one hospital and cardiac care centralising at another. It is logical to build on those strengths. One of the things I think I would just like to highlight is we also already have quite a lot of patient feedback. And Janet, you referred to it because we get it through our complaints. And what do those complaints tell us more often than not? They tell us about systems that are not joined up, systems that are broken in terms of patient experience. So I think we've incorporated a lot of that thinking already in ICANN. And we were also asked what our system partners might say if they saw this and what they will think. I think they would expect us to be addressing the issues around system integration and making a success of ICANN, because as you said, Trevor, if we don't make a success of ICANN, both from a delivery point of view, but also the underlying driver and workforce point of view, we won't make a success of anything because we will simply be overwhelmed by non-elective demand. In many ways, that is at the core of what we have to deliver as a system, and it is at the core of what we're talking about here. How do we explain that to people? We have a huge opportunity, as I said, to build on the feedback that we've already had. What will success look like, to your point, Edmund? I hope I would see two things. One is I hope I would see some new ideas, some things that we haven't thought about coming forward. We've got opportunities in cancer and cardiac to ask people what they want. But also, this will be the first opportunity for us to test our major system transformation program in terms of, does ICANN deliver for people? ICANN is a term that we use internally within the health and care service, but it's not necessarily something we've talked about a lot with patients. So I think it will be a really significant opportunity for us to say, for the thing that most bothers people, which is how they are discharged from hospital, are we making a difference? Are we doing the right thing? So I think, I hope that we get that feedback, and I'm confident that with the engagement strategy that we will. We need to make progress, and the challenges that we've got are there and they're real, and they won't wait forever for us to answer them. So I think I'd just like to end by saying I really welcome the comments and thoughts that have happened, that have been offered today. I also hope that people get the sense that there is a need for us now to start that conversation and engage with our stakeholders, engage with our public, engage with our staff to test what we already know and what we think. Thanks.
Okay, thanks everybody. I think that was a good debate. And it sort of clarifies where we are on a track here. This is a very good clinical strategy, but it's very definitely a clinical strategy written by clinicians. There's just no shadow of a doubt about that. That is the values that come through it. That's what it's talking about. And now we're going to take that out to test it with the public and with partners and with stakeholders, the majority of whom are, of course, not clinicians. So building on the comments about how it has to be rewritten, about the 1-minute version, about the consequences of what a centre of excellence means. These are difficult exercises because in order to get meaningful response, we're going to have to lay that out with some precision. On the other hand, we're trying to say to people, we haven't actually done that yet because we wanted your opinion about it. So this is an exercise as we travel down here where we steadily ask people where they are on it and steadily refine the meaning and the message. I would expect there will be some quite significant comments from public and patient participation groups in particular, and governors really in Kettering, that would point us to some things that are not in this because they're things that clinicians don't particularly think about. And that's fine, that's how you would expect. So we have to go through this, and I come back to my word about humility. We have to go through this and accept that there will be lots of things in this. I agree with all the comments. I agree with Lisa. There are some shopping lists in here, and they don't stand up to scrutiny. So that will be tested in the business case framework and the arguments for doing some things. I think the consequences of these, you know, I think it was Trevor made the comment about we have to understand where our politicians are, both our county councillors, our local government, with their rights of overview and scrutiny, but also our MPs. It's not yet in a way that will fire up their enthusiasm or any other emotion, I think. So that also needs to be thought through, how you turn it into something which presses the buttons that effectively the people who represent the public would want to be pressed. So it's the same question, really. How do we make this publicly centric? How do we make this publicly comprehensible, as we move from it being a clinician document to being a public document? I like the short version. I'm not sure you'll ever get it down to a minute, Chris, but I do like the short version. What exactly does it mean? And some of the one thing, the two bits that bother me a little bit about this is the engagement strategy. I think we should try very hard to link that with the ICS engagement strategy. And I think the inequalities part of the argument, it's a central theme of an ICS. It is the one new objective of government in creating an ICS. And the role of acute trust, it wouldn't have been long ago since there would have been people on this board who would have said inequalities are nothing to do with us. We just treat the people who come through the door. So I think we have moved a distance here, but we haven't moved far enough. And so we've got to link this more explicitly to the business of tackling inequalities in order to make it really fire in an integrated care system world and build on the support of the partners that make up that integrated care system. So I think those are the two areas that I would ask you to press harder on. Janet, I do hope you're going to agree with me.
I am. I'm actually going to add to that particular point because I feel really strongly, you know, we've done a huge amount of work in this organisation about EDI agenda. And there's been focus on that. And in the inequalities, I think it's about thinking about the population within our area that is about making sure they're included. And I think it is really bigging that up and making sure we test that out with the population.
Okay, thank you for that. I'll come to you in a minute, Simon. My final point is that as we develop in the world of collaboratives, and particularly the elective care collaborative, we're going to have to demonstrate, and there's a lot in this about elective care, we're going to have to demonstrate how when we put a collaborative together led by us, it is better than the current system. So we're going to have to demonstrate that we can think like commissioners and not just be protective and develop more of us scenarios. So we are going to have to work quite hard to develop, because there's very few people on this call who've ever been commissioners. And it is a different way of thinking about how you tackle problems. And I do think we need to think very carefully about how we build that into our thought processes for how to go forward. Final comment, Simon.
On your first point, Alan, I completely agree. And I think it would be a subject that we should bring back to board development, because I think thinking like a commissioner, to parse a phrase of Simon Stevens, which I think was something along the lines of think like a patient, act like a taxpayer. We need to think like a commissioner and act like a provider. Maybe that's our version of that phrase going forward. And in actual fact, I think it would be really worth us spending some detailed time about how our offer could be different and better in that space. I see some nods. Would there be appetite for that at a future board development discussion? So that's the first point I wanted to make. On the second, on your points about inequalities, Janet and Alan, I think that's absolutely right. And I just want to remind people, we did start talking about this at boards a few months ago, about the probably one of the biggest inequalities that we as an acute hospital have to solve first is on our waiting lists. Are we giving people access to treatment in a way that is absolutely fair and equal, no matter where they come from, no matter what their age or ability or gender or orientation is, are we satisfied that we are doing that? And I think that's a rich theme for us to mine. I just wanted to draw attention to that by way of conclusion, because we started that conversation with some quite imperfect data, I think people will acknowledge, a few months ago. And I just wanted to link it finally by way of saying, we start getting the shared care record data through in very early stuff this month. And I think that will also open a conversation to us to say what populations are coming forward to us? Who are we seeing? Who are we not seeing? What does that tell us about how we will shape our strategy going forward? And very final point from me, this is not, even when we've completed this engagement exercise, it's not the definitive last word. This is a document that will guide us over the years ahead. So I do not expect for us to be putting into the drawer and then just periodically coming back and saying, have we done it? It will need to live, breathe and evolve with us as we grow as a group. Thanks.
Okay, thank you, everybody. That was a very good conversation, very constructive, very productive, and I'm sure everybody concerned has been listening very carefully, and there will be bits of it that come back to us repeatedly, and there will be bits of it that we see in other fora that we are part of within the county. So thank you very much for that. The byproduct of which is it's blown my timetable out of the water. So I just mentioned that for future presenters. Mr. Callow, present, please. Digital strategy implementation.
Thank you, Chair. Colleagues, I will canter through this and take the note. When I stood up at the clinical collaboration conference in October, one of the things I said is it's easy to forget how far you've been when you've got a long way to go. And I think that's probably the context of where we are within this digital strategy. We agreed it as boards in March earlier on this year. And I just wanted to take a moment today to actually celebrate the work of the teams across the group on what's been done. That's not to say we've achieved all the things, but I think it is cause for some celebration. So if you recall, the strategy contains 8 themes. Each theme has 3 priorities and a number of measures to be monitored at the 12-month and 36-point marks. Since the strategy is approved, we've done a lot of work to look at how we set some targets, and out of that we've got 96 achievement targets that are associated over the 3-year period. And as you recall, when we agreed the strategy back in March, we agreed we'd do a review at 6 months, and this is that moment. So as a result of the review, there's been no changes to the themes, ambitions or priorities, and progress has been made on every theme within the strategy. A number of the KPIs, those 96 targets, 3 of them have already been complete, and some of them need some adjustment, of which we had a detailed discussion at the Group Digital Hospital Committee. And you'll find in the pack there is the detailed update to the strategy, which I don't propose to go into here. So this is a reminder of the 8 themes, and in the pack what you'll see is there's a format for the update. So the top part of the screen is what was in the strategy originally, and in the bottom provides an update, and the bottom right is an extract from the KPI tracker. So we've got a really comprehensive tracker looking at all those 26 metrics that gets reported to the Digital Hospital Committee each time it meets, and also to the group operational digital meeting in the intervening period. So what I'll do is I'll just pick out 1 or 2 things from each theme just to note for progress, and then we can go into the questions and keep to the timescales. So thing to note from about our patient side of things is we've got in progress this pilot for Patient Knows Best. It's going to be used for advanced care planning and maternity, and that will allow patients to access their records. They'll be able to communicate with clinicians and have some information that's part of their care journey that's shared with them. And that's really going to be a platform that we use across the system for our front door for patient services. In terms of supporting our staff theme, the thing I'd like us to celebrate would be everybody is now across on nhs.net. This period where we've had 2 different email systems across our group is now over, and we can now communicate using Teams all on the same tenancy, and that will allow us to collaborate on documents rather than sort of sharing it by email. So it's been a slog to get there. I know there's been some pain there, but yeah, it's great to get there, which will allow us to then build on that and use the nhs.net credentials, the passwords, as the front door to a lot of our other systems as we work towards that single sign-on target. Doing the basics. So we are in a better position now than we were, say, a year ago in terms of our stability of our networks. We've still got more to do, but there's been more things upgraded across the network, across both organisations over the course of the last year, and that programme continues. But I have certainly felt that I've not had to go into these incident analysis reports half as frequently as I did perhaps 18 months ago. So we're tracking that metric and things are improving on that front. In terms of clinical-led solutions, so we're working towards our group electronic patient record. You may know, as we've talked about it here, that the Northampton funding process is going through this thing called the digital aspirants. That's quite a long process, tortuous process, but what we've done is try to carve out some of the other elements that can be done outside of that process, and we've made some progress on the electronic document management and also electronic prescribing and medicine administration. And key to that is around making sure that aligns with across the group. So we'll have systems that are aligned and allow clinicians to go between our 2 organisations and not have to think, oh, how do I use this different piece of software? In terms of providing insight support decision making, I think we've talked a lot today around the Power BI and the output of the Firebreak to do there, but that's clearly one of the outputs there. There's 3 dashboards now available through Power BI, and more will be emerging over the next couple of weeks. So it'd be good to hear what you're thinking of those. In terms of working with our health and care partners, Simon mentioned the Northamptonshire Care Record. It's due to go live any moment. It may be drift a little bit into later on this week, but certainly all the GP data from EMIS practices is loaded up, and that we'll see over the course of the next few weeks, few months, that more data will be available from other areas, and that's going to make a big difference to direct care. And the knock-on effect of that will be that once that data is in the Northamptonshire Care Record, we can start reporting out of the analytics reporting platform, the NARP. And as Simon referred to, that gives us possibility to be able to report on population health, but also support some of our research ambitions that we've been talking about in our clinical strategy. And you know, if there's one thing that we're hearing from clinicians about their research ambitions, is having a set of paper records, you know, it just makes it really hard or impossible to be able to be involved in longitudinal studies. In terms of connecting our systems, probably one of the things to note there is across the group, we are one of the 2 centres of excellence for robotic process automation that we mentioned earlier on today, offering that out across the country. So 20 trusts are having some support along that, and we're building to make that a more sustainable position as we go forward. And we're on track towards that single sign-on. That's a big piece of work to get to where we are now to work towards that single log-on. And the final thing I'll mention is around collaborating for a shared purpose. So we are working together to work as a digital group across the board rather than 2 separate teams. And the consultation process to put the senior leadership team in place is finished, and we're now in the process of doing the post consultation process to get those people in post, which will make a big difference. So I'll just conclude by asking colleagues to note the progress to make, note the changes identified in the report that is included in there, And we will continue to monitor the strategy as other things come through. So, for example, as the clinical strategy continues to evolve, we'll keep an eye on whether there's anything in there that needs to be incorporated in the digital strategy. So I'll finish there. Happy to take any questions.
Okay, thank you very much, Andy. It's good. It's a very good update, and that's exactly what the board wanted when they asked for 6-month updates on this. Any questions or comments? Debbie?
Yeah, thanks, Chair. Thanks for that, Andy. I'm really looking forward to seeing the shared care record. I just wanted to comment on the BI work actually that the team have been doing. It's fantastic. And I know that it's still work in progress, but it will make such a difference for the staff in the organisation, just being able to have that information at their fingertips. So thank you.
Okay, any other comments at all on this other than, yeah, good stuff. Keep it going. Because we're never happy, Andy, remember? But it's good stuff. Okay, Lisa, yeah, same comment. Yeah, okay, thank you very much, Andy. That's very good stuff. And now, UHN academic strategy, and we have Kay with us, Kay Faulkner, at least I hope we do, who is who's going to be part, at least, of the update on the implementation of the academic strategy. Rabia, presumably you're starting this? Somebody?
Good afternoon, everyone. I'm Kay Faulkner. I'm the Associate Director for Research, Innovation and Education, and I'm delighted to be here today to give you an update on our academic strategy. Next slide, please. So we have got our academic strategy. It came up to its first birthday this month, and this focuses on 3 or 4 main areas. One is around our partnerships with our university partners, the University of Leicester and the University of Northampton, and those partnerships will develop over time. We had some key objectives which I will share with you that we've achieved for this first year of the academic strategy. We've then looking at our culture, really, in terms of developing a strong research culture, and it was mentioned earlier around utilising the academic strategy to support us, so we are research active, growing research leaders of the future, so we can impact on recruitment and retention of our workforce to create that impact and to reduce the spend on our locums. We know this is a long-term investment. If we're looking to grow our own workforce, a part-time PhD, for instance, can be up to 6 years. So this is a long-term strategy whereby we are growing the research culture across our hospital group and across all of our professions. This just isn't for our medical colleagues. This is for all our clinical professions to become engaged in research. We need to look at sustainability of our plan as well. Key to that will be new people in post as research leaders to grow the numbers of research grants and to support those partnerships with our university colleagues to bring in NHR infrastructure and additional funding that we wouldn't necessarily have had access to without those partnerships. And we want to make sure that our clinical placements are top ranked, that we're providing the best possible placement experience for all of the students that are coming across our hospital group as they develop and go through their training. And lastly, we spoke quite a lot about comms this morning, and this is about promoting our academic brand, that people are clear in terms of what we're doing in terms of our research, that they want to come and work here, and that our patients are aware of the impact that our research is having across Northamptonshire. Next slide, please. So I just thought it'd be helpful just to run through the benefits of our academic strategy. So for our patients, through our growth in our research and our growth in our clinical trials portfolio, they will get access to new treatments that wouldn't necessarily be available through standard care. And they'll also be able to be part of nationally large data sets and large amounts of research to help improve diagnostics and provide support for new treatments as well. And they'll be able to support the workforce of the future by working with our students that are on placement here. And that's vital to have that learning culture across our hospital group. So for our workforce, they'll be able to engage in research and have their research careers here across our hospital group. We are going to be creating clinical academic careers, and we are investing in 10 clinical academic posts, which are funded by the academic strategy. But beside that, we also want to grow our own. We want to grow the numbers of research active members of our staff, and we've made some great strides this year in terms of successes of supporting NMAPs on regional training programs so they can become clinical academics in the long term. So that's a dual strategy of supporting the clinical academic careers, firstly through the academic strategy, pump prime investment, and then growing our own. And obviously through that, we want to make sure that we are an employer of choice post-qualifying through by providing a great research and learning environment for everyone who comes to work across the group. And for us as a group, we know nationally that there are lower mortality rates for those hospitals that are research active. We know there are improved recruitment and retention of clinical roles that want to come and work in a university hospital. We will gain from our research portfolio by being able to trial new treatments and new diagnostics and the efficiencies that come from that, particularly as we focus on growing our commercial trial portfolio. And we want to be credible as a hospital group for people to come to work here, and also for our populations that they've got confidence in us, that we are research active and we are training the workforce of the future. Next slide, please. So this is our vision. So I've mentioned about the people. It's really important that we employ our first group of 10 clinical academics in post. That was a criteria for us to become a university hospital, but it doesn't stop there. That is our starting point. We want to provide a career pathway for anyone interested in research, to support them as they grow and have their careers here across our hospital group. We want to embed the Associate PI scheme, which supports new researchers running clinical trials. And we want to support our medical education workforce and grow the numbers of medical education fellows we employ. And in partnership with our university partners, particularly the University of Leicester, we have been able to put in 2 large bids this year, one being a National Institute of Health Research Biomedical Research Centre bid. Leicester are one of 26 centres to be shortlisted, and we are a partner on that bid. And this is a great success for Leicester. Places like Liverpool University and Liverpool University Hospitals didn't get shortlisted, but Leicester did, and this is a great game changer opportunity for us to be part of the BRC. And in addition, there was a separate bid to have a clinical research facility, which we will work again in partnership with the University of Leicester on. All of those bids are getting assessed at the moment, and we'll know more come March, April time. That's been a great testament to our partnership in the last year for us to be on those bids, and it will really solidify those relationships we've got with the University of Leicester. So we want to grow our income from research grants, from that income generated through having more clinical academic posts, from a wider portfolio of clinical trials, from hosting more medical students and growing our education offers as well. And from the innovation perspective, we've just got our first trademark, and we're currently in negotiation for our first license deal. And we want to grow our innovation opportunities. So where clinicians have got opportunities to commercialise their research, we will be able to do so and bring in additional revenue to us. So we want to make sure that our patients as well are engaged in the research that we do. We know we haven't got the diversity in our patient populations that are recruited onto clinical trials. And we want to make sure that that research also reflects the needs of our populations. So I chair the ICS Research and Innovation Group, and we are looking at how we can work much more collaboratively across the system to make sure that we are growing our research active workforce and that we are increasing diversity in our patient groups across health and social care to engage in research. I've spoke about that research growth in terms of growing research grants and applications, but also growing the numbers of masters and PhDs and our publications that we will be producing, and that will have a knock-on impact on our reputation as a university hospital group. We want to look at how we can embrace multi-professional training across all of our clinical areas to create the best possible placement experience for those who come to us as a hospital group. And just picking up on Andy's point as well, that efficiency in clinical trials, it's very paper based, it's very costly. We are costly as a university hospital group with our clinical trials at the moment. And we will be embracing all digital transformation to enable us to be competitive, to pitch for those commercial trials and embrace new technology. When we get EPR and all of the developments that Andy's spoken about, research needs to be at the heart of that digital transformation to gain the efficiencies that we need. Next slide, please. So just a brief overview in terms of where we are in the last year. So we obviously approved the academic strategy, we had the business case approved, and we signed our partnership agreement with the University of Leicester last year. In July, we launched University Hospitals of Northamptonshire, and we started the ICS Research and Innovation Group. And internally, to manage the academic strategy, we set up the Academic Strategy Programme Board, which is our internal governance, which tracks progress, risk, and financial spend, and that reports into the Joint Quality Committee. In August, we launched some internal funding in terms of the Early Career Research Awards, and we took our largest ever cohort of medical students. That was 128, up from 96 in 2019-20. And we will grow the numbers of medical students to 148 by 23-24. So September, we worked on those partnership bids that I mentioned earlier with the University of Leicester, which is the BRC and the clinical research facility. We expanded our teams and started our joint recruitment for new post support, expanded research teams and expanded medical education posts. And we also got success in terms of 2 nurses and 1 pharmacist onto regional clinical academic programmes, which is absolutely fabulous. And in addition to that, we have had some delays with the Royal Colleges to approve our clinical academic posts. We're still currently 2 outstanding, but we will be progressing that as soon as we can. And that is in partnership with the University of Leicester. In addition to our partnership with the University of Leicester, we've also set out a joint partnership with University Hospitals of Leicester. So we are looking at joint processes for clinical trials set up to gain efficiencies not only across UHN, but also in partnership with University Hospitals of Leicester to reflect back post-COVID, where clinical trials were set up very, very quickly. In some cases, Leicester UHL set one up in 6 hours, which is unprecedented. And it's how we can benefit from that partnership as a group to improve our efficiency so we can do more with less. So the last slide, please. I won't go into detail of this, but this just gives you some of our successes around our placements and our research in terms of trial participants and what we're doing in terms of expanded teams. But we've had a very, very busy year with the academic strategy, and this is only the start, and we're really looking forward to developing those relationships with the University of Leicester, the University of Northampton, and in the ICS as well, to enable us to work across the system as we develop and implement the academic strategy. More than happy to take any questions from the board.
Okay, thank you very much, Kay. That was very good. All energy and enthusiasm always plays well in a board meeting, and that's what you give us, energy and enthusiasm. Now, I have a hand up in the top left corner, but I don't know who. Oh, it's Edmund. Edmund, your camera seems to be. Are you there?
Oh, I don't know what's. Yeah. Sorry about that, Alan. It was showing. Somehow the camera had switched to show my desktop rather than me. I realise that time is pressing, Alan, so I won't take long. I just want to compliment what was said there. The university is really pleased with how this partnership is progressing and with how the strategy is progressing. I think it's a very, very fruitful partnership.
Okay, thank you for that. Any other comments at all? No, I'm not seeing anything. I think I've encapsulated it. Okay, comes across really well. It did at the Northampton board. It does at this board. I know when the business case came forward, there was a little bit of skepticism and a little bit of, oh, I don't think you're ambitious enough here. And it went round the houses a couple of times before it got approved. And I think that's proved to be the right thing to do, really, because now you're demonstrating that we're running pretty hard against the business plan. So well done. Congratulations to all who've put it together. As ever, lots more to be done. And, you know, hospitals that do research just have better outcomes for patients, and hospitals that do that develop clinical academic leadership are the kind of places that raise qualities and standards. I learned that quite a long time ago, and it's undoubtedly the case today that that's how we will raise those two things together. Will be the single biggest things that raise the standards of our clinical services. Simon.
To congratulate the work, as others have done, to respond to Janet's question in the chat, and just to let the board know that Alan and I are meeting the University of Northampton board, I think in January now, to consider how we might take forward partnership opportunities with them. They are very keen to do this. We are very keen to do this. So I just wanted to take the opportunity to respond to that question. Thanks.
Okay, thanks everybody. Thanks, Kate. I know we cut you a little bit down on time, but we didn't really have a choice. Thank you very much for your contribution today. Right, so now some governance issues. Board assurance framework. This went through the NGH board. This is the group and KGH BAFs, along with a schedule of changes. Anybody have any comments on them at all? Because it's been through the process, there shouldn't be an issue. No, good. Thank you very much. You can take those as received. SDC, terms of reference, again, that went through the Northampton board. This fundamentally just turns it into a committee in common. Now that Northampton is in line to be, well, hopefully in line to be a HIP 3 scheme, it would seem reasonable we give a modicum of thought to how we take the two issues together. Anybody got any comments on the issue on the terms of reference? The key people involved obviously approved it at the committee, Lisa and Trevor and Polly. No, good. Okay, thank you. Non-exec directors to committees. You have the list before you. Anybody who has any complaints or any desire to do something different, please talk to me in private, and we will try to accommodate your career aspirations as best we possibly can. or even just your diary aspirations. So that's the list, and I think it's helpful. If it's not complete, please tell Richard, and he will add in, because I think it's good that people, particularly governors, but others as well, can see the breadth of what you're doing. Just as an aside on that topic, there are apparently 16 things non-exec directors should be named as responsible for, and that's being whittled down to 5 nationally, at least one of which I'd never heard of before. So yeah, well, there you go. And we will just come back round to cover that. The main ones, and I think they're legitimate, are health and well-being, the freedom to speak up, and the maternity services, all of which we do very well. There are a couple of others which are a bit more esoteric. Anyway, that will come out before Christmas with a bit of luck, and that will simplify the individual non-exec director responsibilities, everything else being taken through committees. Okay, and finally, Debbie, DIPSI arrangements, the Director of Infection Prevention and Control changes at Kettering.
Yeah, thank you, Chair. So this is a formal note to the board just to let you know of the changes to the Director of Infection Prevention and Control. I'll take the paper as read, happy to answer any questions, but would also like to just take the opportunity to say a huge thank you to Manjula Natarajan, who has given many, many years to the organisation, not just as the DIPSI, but also from a clinical point of view within pathology. So thank you, Manjula, for everything that you've done.
I'm sure everyone would go along with that. Manjula was quite for somebody who was about 4'6" tall, she was quite a remarkable force of nature when it came to infection control processes. Chris.
Thank you, Alan. I was just going to mention Manjula, but the one thing that you don't know is that Manjula's work with the mortality review process is exceptional, as well as being the DIPSI. And thanks to her, I've been able to export the processes that are working so well at Kettering to other parts of the NHS. So it's thanks to her.
Yes, you know, it's easy to underestimate the effect of people who, you know, slightly operate in the background over many years, but there's no doubt that the openness, the learning, the reflective processes, the mortality review stuff, the learning Friday learning experiences and so on, I can't remember quite what they're called here, are really quite unusual. You know, if you haven't been in the health service a long time, you might begin to think that's normal stuff, and it absolutely is not. It's quite unusual stuff, and much of that goes down to Manjula. So yeah, anything more we can say that's nice about Manjula, I'm sure you can take it as read. So thank you very much for all of that, and that brings it in line with the Northampton arrangements, where the Director of Nursing is responsible for infection control and prevention. Okay, I don't have any questions from members of the public. Is there any other business? No, good. Can I ask you to pass the resolution to exclude representatives, press and public for the remainder of the meeting in regard to confidential nature of the business? Nods will suffice. Thank you very much. And you are now going to a new link, which will be on